Good morning, everyone, and thank you for joining us today. My name is Nidhi Agrawal, and I'm the Medical Director of Pituitary Diseases at NYU Langone Medical Center. We are so thrilled to have so many of you join us today to discuss the different management modalities and overall treatment outcomes in patients with acromegaly. I wanted to thank all our wonderful speakers who've shared their Saturday time with us. We know it's not easy, so thank you so much for being here. Thank you, of course, to all the attendees who have logged in, and a special thank you to all the sponsors for helping support this event. I also wanted to introduce my co-host for this morning, Dr. John Golfinos, who's the chair of surgery. Dr. Golfinos is the Joseph Ransohoff Professor and Chairman of the Department of Neurosurgery at the NYU Grossman School of Medicine. He trained in neurosurgery at the Barrow Neurological Institute, and he served as chair of the NYU Neurosurgery Department for more than 30 years. He co-founded the NYU Gamma Knife Radiosurgical Unit in '98, which is the first of its kind in New York City. He also co-founded the NYU Neurofibromatosis Center, which is the largest center for patients both with NF1 and NF2. He is currently the co-director of the NYU Brain and Spine Tumor Center, and I am thrilled to say that he's going to help me with co-hosting this event this morning. So thank you so much, John, for being here. And if you wanted to say a few words.
Sure. I think, can you hear? Yeah, it's wonderful to be here. You can see the sun is low over the East River this morning as we get into late October and early November. But it's really terrific to be here. And I just want to thank Dr. Agrawal for doing an unbelievable job on getting this together and really making a big impact on patient care. And I will say one thing, I don't know what the greatest credential can be, but in my mind, I think Dr. Agrawal's greatest credential is that her patients love her and that she is really a brilliant physician. So it's really a great pleasure on my part to be here and to participate.
Thank you, Dr. Golfinos. We will start the event now, and I'm going to start with the first talk this morning. Again, thank you to all our sponsors. And the first talk is going to be just an introduction, an overview, and diagnosis of acromegaly. And just to remind ourselves, the pituitary gland is really a very small pea-sized gland, which is present behind the bridge of the nose, as you can see in this picture. It is managed and modulated by the hypothalamus, which is one of the higher brain centers, and that's kind of what helps to direct the pituitary and help it with its function. We know that the hypothalamus, as you can see in this picture, is really the main kind of the director of this master gland called the pituitary. The pituitary has an anterior portion and a posterior portion. The anterior portion is larger, which is right here. And this is the one that makes the bulk of the hormones. And then, of course, there's a smaller posterior portion of the pituitary as well. So almost all the signaling or the functionality of the pituitary is really modulated by the hypothalamus. So it's extremely important to have this intact mechanism for good hormone functioning. Today, of course, we're going to focus ourselves to growth hormone, which unfortunately the excess of causes acromegaly. So before we move on to details of acromegaly and just go into the disease itself, I wanted to just remind everyone here the basic anatomy and where the pituitary is housed. And so this is what we call a coronal view. It's a frontal plane. And this here, right here, is the pituitary gland. And as you can see in this diagram, there are very important structures around the pituitary. So right here on top is the optic chiasm, which is the nerve that helps to control vision. On the sides are the blood vessels and also important cranial nerves, which help to control vision, facial movement, and sensation. And right here inferiorly is the sphenoid bone, which is the bony structure. So if a patient has a tumor, which I've depicted in purple here, and if the tumor grows, then one of the structures that might get compressed is actually the superior optic chiasm. And one of the manifestations of this happening could be visual disturbances and difficulties. Of course, any pressure in the pituitary can also give you headaches, and it can compromise the rest of the pituitary hormones in the area. So what is the normal physiology of growth hormone production? As you can see here, the hypothalamus, as we said, is the higher center that controls all the hormones that come from the pituitary. That makes a hormone called GHRH, or growth hormone releasing hormone, which acts at the level of the pituitary, and it helps it make growth hormone. Growth hormone then acts at the level of the liver, and it releases insulin-like growth factor. This mechanism is kept in check by something called somatostatin, also called somatostatin receptor inhibiting factor, or SRIF, and that basically keeps this whole process in check in a normal individual. What happens with growth hormone secreting tumors? So in acromegaly, there is a tumor, as you probably know, and this starts making excessive growth hormone, and that acts at the level of the liver then, but now the IGF production is really pronounced, and that leads to the peripheral effects of growth hormone excess. Now, of course, we call these tumors, but the good news is that almost 96, 98% of these are completely benign. It is just an overgrowth of a growth hormone producing cell, but these are not cancerous. Growth hormone hypersecretion is really the underlying pathophysiology of the manifestations of growth hormone excess. So as you can see in this picture, on the left, you can see that growth hormone really has a spike, which happens more during sleeping hours, and then it comes back to the baseline in the morning. These spikes, which are usually 10 to 12 in a day, happen more when the person is sleeping. However, in acromegaly, unfortunately, the levels of growth hormone continue to be elevated, and they never really come back to baseline. So it's just a consistent elevation of growth hormone, which ultimately leads to manifestation of disease. I wanted to just mention pituitary gigantism, which occurs when there is excessive growth hormone levels, or IGF, but this happens before the growth plates fuse. So one of the manifestations of gigantism is tall stature, because the child is still growing. Acral enlargement, facial changes can be seen as well. And there is a slight male preponderance as opposed to acromegaly, which we'll just discuss in a second, which perhaps is a little more common in females. Approximately 50% of patients with pituitary gigantism have an underlying genetic cause. And acromegaly, of course, happens when that excess is occurring after the fusion of growth plates. So in the inset here, you can see a picture of a 12-year-old boy. He's 6 feet 5 inches, and he's standing here next to his mom, and he suffers from pituitary gigantism. So just a few facts about acromegaly. It is a rare disease. Older studies have shown that the prevalence is 5 to 6 per 100,000. There is newer data now, especially a new meta-analysis which was just published, which shows that this number could actually be higher. It could be between 13 to 14 per 100,000. Now, why is this? This is, of course, because patients have longevity, there is increased prevalence of disease. We know more about acromegaly now. The diagnostic criteria of acromegaly is changing as well. So that could possibly be pushing this number to a truly kind of a higher number of 13 to 14. We know that these are most commonly because of growth hormone producing pituitary tumors. Approximately 95% of acromegaly is indeed central, coming from pituitary sources. And most of these tumors, and this is mostly because of the delay in diagnosis of acromegaly, they present as large tumors greater than 1 centimeter. 90 to 95% of these tumors are sporadic, so not necessarily genetically driven. I think this timeline is important to highlight because I think over the last few decades, we've been doing slightly better in terms of delays in diagnosis of acromegaly. But of course, I think we are still light years behind. We have to do so much more as a medical community to make sure that we diagnose patients with acromegaly early. So this was a large European study which showed that, more than 20 years ago, or in the 1900s, excuse me, there was a more than 20-year delayed diagnosis of acromegaly. In the 1990s, we were a little bit better at, say, 10 years or so. And then recent literature is showing that that delay has been cut down even more to 4.5 to 5 years. So again, I think this is an improvement, which is great, but there's still a lot of work to be done in this realm of acromegaly. So over the last 20 years or so, we've understood a lot about the molecular diagnosis and the genetics of acromegaly. And I'm not going to go over each disease on this table, but just to highlight that there are genetic syndromes, both germline mutations and of course the somatic mutations that I put in purple here, but these can indeed happen in some patients with acromegaly. They are more common in pituitary gigantism. Approximately 50% of those are genetically driven, but it's definitely possible in patients with acromegaly as well. Just wanted to highlight AIP here is a familiar acromegaly syndrome. It happens in patients who are usually younger than age 30 at the time of diagnosis, and it can give you pretty aggressive invasive growth hormone secreting tumors. And XLAG, which is another one that I wanted to highlight here, can happen very, very early in life. So as early as 1 year of age. And if the baby starts growing in an accelerated way, that is something to think about in young children. Somatic GNAS mutations, which is this area in purple that I highlighted, this is actually being studied more and more, and it perhaps is present in 40% of patients with acromegaly, and there is some data to suggest that they might be better responders to medications like somatostatin receptor analogs. So as we said, as you can see from this diagram here, there is genetic predisposition in pituitary gigantism, approximately 50% or so, but it's not very clear what those numbers are in acromegaly. So just a word about, this insidious kind of the facial changes that happen in acromegaly, which, as you can see from this diagram, can very well be confused with just normal aging. This is, of course, it's a picture I got from the internet, and you can see this is her progression over years. But there are very subtle facial changes. There could be some coarsening of the facial features, and of course the jaw prominence and so on. But you can actually see how this could be mistaken for just normal aging, leading to an overall delay in diagnosis. So that's the reason we need more education, we need more awareness, and definitely better screening tools. I wanted to take a few minutes to talk to you about gender dimorphism in acromegaly. So in other words, is acromegaly different in males versus females? And this is something that has really gained a lot of attraction in the last few years. There are some studies which talk about how this is exactly the same in males and females, but newer studies are now talking about a slight female preponderance. It's not a huge delta, it's 53%, so just above half. But it's definitely interesting that females might be slightly more predisposed. We also know that estrogen, which is the main female hormone, has a growth hormone protective effect, especially at the level of the liver. And that's why the IGF-1 levels can be slightly lower at the time of diagnosis. So this can, again, delay the patient's diagnosis. In females, there can be a delay in diagnosis of approximately 4.5 years. And this might be just maybe 1.5 years or so more than in men. Because of the delay in diagnosis, females can potentially have larger tumors with more extension to the cavernous sinus. The quality of life could be lower, and metabolic diseases like hypertension and diabetes could be a little more frequent in females compared to men. This is a large study which comes from France, and it's interesting because they actually looked at how the patient presented. So these are patient-reported symptoms and also how the physician interpreted them. And very interestingly, men actually presented more with snoring, and we do know that sleep apnea can be a little more common in men than in women. They also presented more with acral enlargement or enlarged hands. In females, they had more constipation and thyroid nodules as the presenting symptoms. So of course, there are more studies that need to be done to really tease out what the true gender dimorphism is in acromegaly, but it's interesting that even their reported initial symptoms were different. I really like this cartoon that I picked from the NORD, or the National Organization for Rare Disorders. And it really highlights, the challenges in acromegaly. So for any rare disease, as you can see, from the start of symptoms all the way to the correct diagnosis, there's a huge pathway that these patients have to follow. And of course, that leads to an overall delay in diagnosis. It's really a very, very challenging entity, and making sure that you're getting to the right provider is extremely important. And so just to follow up on this, the first point of contact is very important. So when the patient presents to you with the symptoms, it all depends on how the practitioner is interpreting that and if you're being screened or not so that you get the correct diagnosis. This was a large study. It was done in 300 patients, and this is by Dr. Naktigal's group. And you can see here that, in this particular study, it was really the primary care who was the leading, the PCP or the primary care, where the patients first presented and they were the leading physicians diagnosing acromegaly. Of course, endocrinologists are very commonly seeing these patients as well. I can tell you in my patient panel, I have several patients who've come to me from gynecology because of fibroid tumors which are bleeding. I have patients who see me from the dentistry service. I also have patients who've come in from neurology for carpal tunnel syndrome. So it's definitely something to keep in mind. This is another large study done in 3,000 patients, again, highlighting how important that first point of contact is. And you can see here that almost all subspecialty here is, or potentially could be involved in the first diagnosis of acromegaly. So I think awareness is key. We need to do so much more to go out in the community, talk to other subspecialties, and make sure that, we are all aware of the diagnostic challenges of acromegaly. So why is that and what are these features? So here you can see in the first picture that there could be some spaces in between the teeth. There could be a prominence of jaw. There could also be a large tongue, as you can see in the second picture. And this can, of course, be picked up by, say, a dentist, when they're first seeing the patient. Carpal tunnel syndrome, which is numbness and tingling at the level of the wrist, which happens because of the compression of the nerve in that area, can be picked up by a neurologist. And there are studies now which show that carpal tunnel syndrome is 6-fold more common in patients with acromegaly, and it can actually be the first manifestation of disease. So again, something to really keep in mind. Skin tags can happen, and the dermatologist might pick these up and send the patients to the endocrinologist. And then, of course, sleep apnea can be the presenting feature in 60 to 90% of patients with undiagnosed acromegaly. So this is a very old study now, but extremely relevant. Again, talks about how acral enlargement and or coarse features are very common in patients with acromegaly. There can be increased sweating, and that's because increased sebaceous excretion from the glands could happen in patients with acromegaly, and women can present with menstrual changes. There are lots of different ways of looking at the signs and symptoms of acromegaly. Local tumor effects, headache and vision could be affected. And of course, overall pituitary hormones can be reduced as well. And there are physical changes, as we just discussed. I'm going to go over the systemic manifestations of growth hormone excess because I think this is important. And as you can see here, hypertension and cardiomyopathy and just overall cardiovascular risk can potentially be a little bit higher, 30 to 60% in patients with acromegaly. Insulin resistance and diabetes can happen in 30 to 40%. Up to half of the patients can have colonic polyps. And arthritis and osteoporosis can also happen in more than 70% of patients presenting with acromegaly. Sleep apnea, as we just discussed, is also extremely common. The ones which are starred, so hypertension, cardiomyopathy, and arthritis, are actually the complications which unfortunately are not completely reversible even after the patient goes into remission. So along with the systemic signs, not to forget the effect of acromegaly on mentation and mental health. And this is a very important study. It was just published. It's a cross-sectional study done in a large number of patients, and they showed that in patients with acromegaly, depression, anxiety, untreated sleep apnea, and cognitive dysfunction were a lot more common when compared to patients without acromegaly. Along the same lines, this is a US-based study which shows that in patients with acromegaly, there are lots of comorbidities and other medications that patients have to use. Analgesics for pain, and this is mostly for arthritic pain, that they almost always have to use. And just to highlight here that the use of psycholeptics, so antidepressants, anti-anxiety medications, anti-psychiatric medications, all of these are also very commonly used in patients with acromegaly. So I think these studies really kind of highlight the unmet need for a focus on mental health and acromegaly, which I think is coming to prominence more and more. There is a lot to say about overall assessment. I think a lot of my patients would know that I'm really particular about these screening tools, but there is an echocardiography that is recommended annually, and then every 2 to 5 years if it's normal. A sleep study should be done because of the effect on sleep apnea. fasting blood glucose or OGTT every single visit or every 6 months or so. Other pituitary hormones should also be checked. A bone density should be done annually or every 2 years. And then there should be some vertebral x-rays, especially in patients who are high risk. Colonoscopy should probably be done at diagnosis and every 10 years or sooner if abnormal. And an acromegaly quality of life questionnaire is also recommended annually and perhaps maybe at every visit as well. Just a quick word, and we'll go over this in more detail later, but a quick word about biochemical confirmation and imaging. IGF-1 is the main screening tool because it's a stable molecule. We look at the age and the gender matched IGF-1 molecule. It does not change with the time of day. We can really check it anytime with or without fasting. And the oral glucose tolerance test is the main confirmation method to look for acromegaly, and the inability to suppress growth hormone to less than 0.4 on the newer assays is how we diagnose patients with acromegaly. Just a quick word about the different assays and measurement, and this is something that's coming more and more into prominence. I'm not going to go into details, but just to highlight that the growth hormone cutoffs have become much lower for all different assays and for all different diagnostic tests. And for insulin-like growth factor, always better to keep in mind that the same assay should be used for diagnosis and also for long-term follow-up, because there might be some variability in the interpretation of different assays. This is a very old study now, but it highlights that the overall mortality of patients with acromegaly could actually be very similar to the unaffected individuals if we control the growth hormone levels to less than 1, and if the IGF-1 is completely well controlled. So extremely important, again, to look for biochemical control in these patients. What's the future? So this is it's a very nice Chinese study done in over 500 patients. This looks at a computer software, which can basically look at old pictures of the same patient and try to see if there are changes concerning acromegaly. And it was pretty accurate, actually, in the overall diagnosis of disease. I'm going to end with this picture, which I really like, and I think it's a beautiful snapshot of patients with acromegaly. This comes from the Spanish acromegaly registry. These are beautiful pictures there by Raquel Cirici, and she just highlights all these patients at different phases of life, and she says we all have something that makes us grand. Thank you so much for your attention, and happy to answer any questions. If you could please put those questions in the Q&A section during the break. We're going to move on to the next speaker, and that's Dr. Young. Dr. Young completed his medical degree at the NYIT College of Osteopathic Medicine, his radiology residency at St. Luke's Roosevelt Hospital Center, and neuroradiology fellowship at NYU. He joined the NYU faculty practice in 2016, and while at NYU, he's been awarded numerous teaching awards for his efforts in medical student and resident education. Dr. Young and I work very closely for our monthly neuroendocrine conference, and I can tell you he's very popular and a wonderful teacher. Thank you so much, Dr. Young, for being here.
Thank you so much, Tiago. So thank you for having me here. It's an honor. So today I'm going to talk about advances in pituitary imaging and kind of how we do it here, and a basic approach to looking at the pituitary gland, which can be somewhat complex for those who don't look at it all the time. Right, so pituitary imaging at NYU, we need and we usually produce high quality, high resolution images to evaluate the pituitary gland. And how do we do that? Well, we have the latest hardware, the latest generation of MRI scanners, including the 3 Tesla magnets, right? We're fortunate here to be a test site for Siemens, who makes our scanners, so we get the newest toys when they come out, right? We have advanced software to look at the pituitary gland, and one of that software is called the GRASP. It's called the dynamic GRASP, and this is a really high resolution dynamic sequence that really gives us fine detail of the pituitary gland. And then we also have some great people here at NYU. We have technologists who make the images, and we have some experienced neuroradiologists who actually read the images. Another tool that we have here at NYU is the intraoperative MRI, and this really is useful for giving the surgeons real-time feedback allowing them to do a more complete resection in one OR visit. So we'll start with the basics. How do you look at pituitary images, specifically MRI? So we'll start with imaging planes. Right, so there are three primary imaging planes that we use in neuroimaging: the axial plane, the sagittal, and then the coronal. Right, so the axial like slices the body. Sagittal is from front to back, so you're kind of looking from the side, and the coronal plane it goes from right to left, and you're looking at it from the front. So here's an example of an axial plane, right? So it's like slices through a loaf of bread. In imaging and radiology, you have to get used to that these sides are kind of flipped. So the left side of the screen is always the patient's right, and then the right side of the screen is the patient's left. Kind of like you're looking at the patient from their feet up. Towards the top of the screen will be anterior, and towards the bottom of the screen will be posterior on the axial plane. In the sagittal plane, we're looking at the patient from the side. So by convention, the left side of the screen will be anterior, and then the right side of the screen will be posterior, and then towards the top of the screen will be superior towards the top of the head, inferior towards the feet. And then coronals, it's like we're looking at the patient from the front. So superior is towards the top of the screen. And again, the left side of the screen is going to be the right side of the patient, and the right side of the screen is going to be the left side of the patient. All right. So as mentioned earlier, the pituitary gland is a very small pea-sized gland kind of situated in the center of the head, right? So a lot of complex anatomy there, which makes imaging somewhat of a challenge, right? So we'll go into some anatomy and how to even spot the pituitary gland, and then some normal anatomy, and then we'll look at some pituitary tumors. Right, so the pituitary gland here, again, a pea-sized organ, right, housed in the sella turcica, right here, part of the sphenoid bone. We have the sphenoid sinus here and the clivus. So we can see how the neurosurgeons will approach these tumors through the nose, through the sphenoid sinus, and get to the tumor through this approach. Here's a CT of the bony anatomy. So usually CT is a lot better for the bones. MRI is a lot better for the soft tissues, including the pituitary adenomas. So this is a sagittal view looking from the side. This is the nose, right? And then back here, this black area here is the sphenoid sinus, one of your paranasal sinuses, and it's black because it's filled with air. And then we have this little indentation here. This is a sella turcica, the bony housing of the pituitary gland, where the pituitary gland would sit right here. Looking at MRI, so again, MRI is much better for the soft tissues, the non-bony structures. Just for reference, this black area here is the sphenoid sinus, right? And then this is the sella turcica. And then here we have the pituitary gland. So this kind of, to me, looks like a woodpecker. Here's the beak, right? And then the pituitary gland is sitting right here like a cherry, right? So find the woodpecker, and then look at the beak, and then this gland here is the pituitary gland. The other anatomy that we see in this this view, we see the optic chiasm right here. We can see how close that is to a pituitary gland. So if you have a pituitary tumor that expands up, it can cause vision loss by compressing this optic chiasm or optic nerves. We see the pituitary stalk, or pituitary infundibulum, which connects the pituitary gland to the hypothalamus. And the hypothalamus is, you can think of it as around here, and the beak of the hummingbird, or the woodpecker right in here. We see up here the corpus callosum, which is a large white matter tract which connects the two sides of the brain. And then going lower, the neck of the bird, this, we're getting into the brainstem. This is the midbrain, pons, and medulla. And then back here, we have the cerebellum. So we'll look a little closer, zoomed in on our woodpecker. Here's the beak, and here's the pituitary gland. We can see the pituitary stalk or pituitary infundibulum here, and then optic chiasm. The coronal gets a little bit more complicated, so I'll walk you through how I approach these images. Right, so as she showed earlier, right, we have the pituitary gland here, and then we have these blue areas here. These are the cavernous sinuses. So these are blood-containing spaces, which house a lot of important structures, right, including the carotid arteries here in red, and then multiple cranial nerves. A lot of them control your movement of your eye. Here's the sphenoid sinus right below. So this is a coronal view, right, looking from the front. This is a coronal T2 MRI, a sequence that we do in all pituitary studies. So to find the pituitary gland, first thing I do, I look in the middle and I find these black round structures here, right? And these are the internal carotid arteries, which correspond to this. And these are within the cavernous sinuses here and here. So immediately between the internal carotid arteries is our pituitary gland right here. And then laterally, these are the cavernous sinuses, and multiple cranial nerves traverse here, going, a lot of them going to the orbit. And then right above the pituitary gland, in the coronal view, we can see the optic chiasm. And we see its close proximity to the pituitary gland. So again, a large pituitary tumor can extend up and compress the optic chiasm here. So this is a coronal T1 post-contrast sequence, just another image that we do of the pituitary gland. And for reference here, we'll go through the anatomy again. Here, find the round black holes here, circles. And then immediately between those, right, you'll have the pituitary gland, and then the cavernous sinuses on the side, and then the optic chiasm here. And we can kind of see the pituitary stalk or infundibulum coming down, inserting on the pituitary gland. Here's some sagittal images of the pituitary gland before and after we give contrast. So the vast majority of our pituitary studies, we give contrast, and that helps, especially helps to find the smaller pituitary tumors like the microadenomas. So this is a non-contrast sequence. So before we inject contrast in the vein, we can see the woodpecker here, and here's the pituitary gland. You can see that the pituitary gland has two colors, right? It has this grayish portion here and the bright portion posteriorly. So this grayish portion here on this non-contrast image is the anterior pituitary gland, right, where growth hormone is secreted. And then back here is the posterior pituitary gland, or neurohypophysis. After we give contrast, we can see that the anterior pituitary gland enhances almost as much, and it's almost as bright as the posterior pituitary gland. We can also see that the pituitary infundibulum also enhances, and this is a reliable sign that there is contrast on board. So dynamic pituitary imaging. So every time you order a pituitary MRI, we automatically do a dynamic imaging through the pituitary gland. So what is dynamic imaging and why do we need it? So dynamic imaging is where we acquire coronal images, right, through the pituitary gland during the rapid injection of contrast in the vein. And we acquire images about every 20 seconds for 120 seconds, about 2 minutes, right? And this gives us a curve. And this is on this chart, this red line here, this is the normal pituitary gland enhancement. So after we give contrast, there's a rapid increase in enhancement, it kind of plateaus, and then drops off slowly. All right, so why do we need this? Well, it helps us detect these microadenomas, so the pituitary tumors that are less than 10 millimeters. So adenomas, pituitary adenomas, enhance, but they enhance slower than the surrounding normal pituitary gland. But if we waited long enough, the normal pituitary gland and the adenoma would enhance to a similar degree, and it'd be hard for us to see it, right? So when we do dynamic imaging, we're going to look at the pituitary gland, you know, in the first 120 seconds, and then that's where we're going to see the greatest difference in enhancement and make the tumor more conspicuous, right? So here's the normal pituitary gland enhancement curve, rapid uptake, plateaus, kind of drops off, and here this blue is a pituitary microadenoma. So it enhances, but it doesn't reach the level of the normal pituitary gland. So this difference here is what we can see, right? So in these images from one of our studies, here's a coronal T2, here's a carotid, right? Round carotid flow voids. And then here's the pituitary gland. And then this is the pituitary gland here, and this round darker circle, grayish circle here is the adenoma, right? We have normal, avidly enhancing or bright pituitary gland tissue surrounding the hypoenhancing or darker microadenoma. So this is our graphs sequence. So this is a high resolution dynamic sequence that we helped develop here at NYU, and it's very sensitive to adenomas. So these images are kind of mesmerizing. Here is the pituitary gland right here, and we can see that the enhancement starts centrally and kind of spreads out laterally. And then on the sagittal, here is the pituitary gland. Here's the pituitary infundibulum. You can see enhancement comes down and then spreads out normally. So this gland is a normal gland. It homogeneously enhances, right? So on the next case, we have a case here with acromegaly. Is there a pituitary tumor? Here's the coronal T2. Here's a flow void around black circles. Here's the pituitary gland, and it looks pretty normal. And even this post-contrast T1, which is obtained 5 or 10 minutes out, shows normal enhancement of the gland. So it looks normal on these sequences. However, if we look at the grasp, right, this dynamic sequence early on in the enhancement, it shows that there's this area rounded circle of gray surrounded by this brighter area of normal pituitary gland, right? So this dynamic grasp sequence nicely shows a small microadenoma in the right aspect of the pituitary gland here. Here's another patient with a microadenoma. Right here, cavernous are the internal carotid arteries. Here's the pituitary gland. Here's catching the pituitary infundibulum coming down. And then this area right here, this darker area here is the pituitary microadenoma in the left aspect of the gland, kind of inferiorly. So we'll move on next to larger pituitary tumors, the macroadenomas. And we define a macroadenoma as any tumor greater than 10 millimeters or 1 centimeter. So when these tumors are usually very obvious, right? And what we're looking for here on imaging is what is the large tumor doing to the surrounding structures. So in this diagram, we see this large pituitary macroadenoma. Here's the sella turcica, original where the normal pituitary sits, but we have this large component of the tumor that goes up here. And this is what we term suprasellar extension or above the sella extension. And what did we see that lives right above the sella? We see the optic chiasm, right, for vision, and that's being pushed up and kind of splayed along the upper margins of the tumor, right? So this is how you can get some vision issues with these large pituitary tumors. We see the cavernous sinuses to the side, right? And sometimes the pituitary tumor can erode or invade the cavernous sinuses here. And then the surgeons have to be very careful to avoid damaging the nerves in this region, and it makes it harder to get the entire tumor. Here's the imaging of a pituitary macroadenoma. So we can see we lose the normal pituitary gland. It should be right about here, right? This pituitary is eroded into the air-containing sphenoid sinus and the upper clivus, and has this component that goes up and compressing the pituitary, the brain. If you remember on the prior diagrams, right here around it where the beak was, we have the hypothalamic region, and we don't really see a normal pituitary gland. Here on the coronal, we can see the normal, the black circles. So these are the carotid arteries, right? But we don't see that normal structure, pituitary gland here centrally. Instead, we see this large tumor kind of surrounding the carotid arteries, going both sides here. So this implies cavernous sinus invasion. We can also see that it goes up here into the suprasellar region, and we can just start making out the optic chiasm being compressed here. So this is same patient. You can see the pituitary tumor here surrounding the internal carotid arteries. And then we can see here and here, this is the optic nerves, and then optic chiasm kind of being compressed over the mass. So here and here. So this patient had vision issues. We can also see a large component going up here, compressing what we call the basal ganglia. A very large pituitary macroadenoma. So we have some amazing surgeons here. I'm always amazed at how much of these tumors they can get out. This is that macroadenoma before surgery, then after surgery. So here, this is a very nice resection of that large mass. So here we can see now there's no longer a mass compressing the optic chiasm, right? The cavernous sinuses are, the components in the cavernous sinuses have also been removed. So a very good result after surgery for this very large macroadenoma. Now I'll finish up with our intraoperative MRI. So this is a very useful tool that we work closely with the neurosurgeons on. And this helps provide immediate feedback to the surgeon during the surgery. So after they do initial resection, they'll wheel the patient here into the adjacent MRI suite, and then they'll image the pituitary fossa. And then we'll look at the images, and we'll speak with the neurosurgeons, and we'll decide whether we think there's any residual tumor or whether they got it all. If there's some residual tumor that they think they can still get, we'll take them back into here in the OR and remove that residual tumor. So this is a very useful tool. It gives immediate feedback to the surgeons. And it improves the likelihood of removing all the tumor in one surgery, avoiding a second trip to the OR. So I'll show you a case here. This is a patient with elevated pituitary hormones. The preoperative MRI showed a lesion here in the inferior aspect of the pituitary gland. This is called a microadenoma. Went into the surgery. They resected this. This little black hole is where they, nice clean resection cavity where the adenoma was. However, after the surgery, we see this other area of gray in the left aspect of the pituitary gland that we didn't really see preoperatively. So our thoughts are, because this was removed, this adenoma kind of came into view from kind of shift of the pituitary gland. So after this was seen, the surgeon went back and also resected that additional area of additional adenoma here in this pituitary gland. So here's an example of the intraoperative MRI was very useful, not only the primary lesion that they were going for, but also in a second lesion that was only visible after they removed the primary lesion. Right, so in conclusion, high quality, high resolution imaging of the pituitary gland is needed to identify pituitary tumors and to help guide management, right? If it needs to be resected, you should come here to NYU, right? But we also here at NYU, we work closely with the neurosurgeons with the intraoperative MRI, giving us real-time feedback and allowing us to do a more complete resection. Thank you. I think you're muted.
Thank you. Thank you, Dr. Young. Really fascinating advances in pituitary imaging there. We'll thank you for your time today. We'll move on to the next talk, and we have two speakers to talk about craniofacial features and oral manifestations in acromegaly. It's an absolute pleasure to introduce Dr. Basmod Parod. She completed her internship at New York Hospital Medical Center in Queens and pursued her general surgery training in Philadelphia and Phoenix. She obtained her Doctor of Dental Medicine at the University of Pennsylvania and oral and maxillofacial surgery training at Thomas Jefferson in Philadelphia. She's been at NYU since 2015, and her interests include imaging technology for reconstructive surgery and dealing with oral health and functional rehab in medically complex patients. We also have Dr. Al-Haji, who received her doctorate of dental medicine from Boston University, and she received her Master of Science in Dentistry and Oral Medicine at Case Western Reserve University. She also completed a dental oncology fellowship at Memorial Sloan Kettering, and we are so delighted to have them both here. This is the first time we are going to have a talk on craniofacial features in acromegaly, so we are very excited to hear more. Thank you again for being here. Thank you.
Thank you for having us. We're certainly very delighted to be here and to shed some light on the dental perspective for diagnosing and also treating patients with acromegaly. We first wanted to start off by highlighting a very special article that's co-authored by one of our next speakers, Dr. Dassey. And we, at this point in time, we do consider this article to be the gold standard in identifying what the oral manifestations and craniofacial features are in patients with acromegaly. And what I thought was interesting was that it's highlighted that oftentimes in patients with acromegaly, the first signs and symptoms to arise are actually oral changes. And before we delve into what these oral manifestations are, I just want to spend a moment going over some basic anatomy of the oral cavity. So in a nutshell, we have soft tissue and we have hard tissue. Soft tissues are structures like the lips and the gums. Hard tissue includes like the teeth and the bone that houses the teeth. And when we talk about oral manifestations, we're really looking at all of these structures collectively in order to identify what these oral manifestations are. And I'm just going to go over some basic taxonomy. So who are these oral health care providers? Who are those dentists that are at the forefront of identifying these features? So the first oral health care provider that one typically comes across is a pediatric dentist, which is a specialist. Usually a pediatric dentist does an extra 2 to 3 years of training to treat kids and kids' teeth. And according to the American Dental Association, patients are recommended to see a pediatric dentist as early as 1 year old. And as the child evolves into an adolescent, typically they see an orthodontist, who is also another dental specialist with extra training. And those specialists are really involved with addressing any facial alignment or teeth misalignment issues. And typically patients are seen as early as 9 years old by the orthodontist. And as a full-fledged adult, patients typically go to the dentist or see a dental hygienist every 6 months, who are also there, who could also potentially be there to observe these changes. And if warranted, patients might be referred to an oral medicine specialist or an oral and maxillofacial surgeons to further assess. Now, the first oral manifestation I want to go over is what we call a dental diastema. In a nutshell, what that means is a gap between the teeth. Typically in patients with acromegaly, that occurs between the bottom teeth more so than the upper teeth. And the reason why I wanted to mention it first is because it's considered to be one of the diagnostic criteria to screen patients with acromegaly, and it's the only oral screening criterion for patients with acromegaly. And there are many causes for diastema. It's also important to note that not every patient with a diastema is likely to develop acromegaly. There are definitely a lot of causes, but the cause behind this patient population is a consequence of mandibular overgrowth, which is the mandible being the lower jaw, and a subsequent forceful projection of the tongue, which is what we call a tongue thrust. And another oral manifestation I wanted to go over is a mandibular overgrowth. That's basically a hyperprojection of the mandible, the lower jaw ahead of the upper jaw, leading to an underbite, as you can see here. This picture beautifully demonstrates this, and it was extrapolated from Dr. Dassey's article as well. I just wanted to take a moment to go over what a normal bite looks like. So over here on the bottom, this is an ideal situation where you see that the upper jaw and the lower jaw are in harmony. They go together, sort of like a jigsaw puzzle. They're perfectly aligned. The teeth are perfectly aligned. And on one end of the spectrum, we have what we call a class 2 malocclusion, which means that the upper jaw is way forward than the bottom jaw, and then the exact opposite pattern is a class 3 malocclusion, which is typically a feature that we see in patients with acromegaly. This is a lateral ceph that demonstrates this manifestation. You can see here very prominently the mandibular overprojection. As a result of this symptom, patients often have an open bite, making it very hard for their teeth to come together, and as a result, making it very hard for them to bite into a sandwich. Macroglossia is exactly what you see here. It basically means an enlarged tongue, and a manifestation like this can hinder our patients from being able to breathe, which is why you see in this particular image that this patient actually has a tracheotomy to be able to assist her with breathing, because her tongue is blocking her air passage. And then we have what we call dental anomalies. So these are basically variations of normal. On the far left over here, we have a situation called hypercementosis, which means having extra cementum deposited at the root of the tooth. It's important to realize that this is a benign condition within itself, but it can render dental procedures to be difficult. So if our patients needed a tooth extraction or a root canal, that can be difficult with this condition. So the ideal approach is for our patients with acromegaly to really maintain excellent oral hygiene, such that they do not need to proceed with an active intervention. This is another variation of normal toroodontism. This tooth over here is a reflection of what toroodontism is. The tooth next to it is what we consider normal, and as you can see, the roots are kind of converging together in a normal pattern, but here they're kind of divergent, and similarly, a pattern like this makes it very hard to perform active dental procedures like an extraction or a root canal. So just a few things to keep in mind. There are also some osseous anomalies, bone anomalies. Patients with acromegaly tend to have.
Te dépêcher et sortir de la chambre. Parce que je présente dans 5 minutes.
Sorry.
Je t'ai dit 8h50, c'est pas le moment.
So we have extra bone deposition in patients with exostosis or what we call a torus. So they can either be localized in the lower jaw towards the tongue side or the upper jaw towards the cheek side. This is exactly what it looks like in the mouth. Over here, this is the lower jaw, this is the upper jaw. And we can also have on the other end of the spectrum an excess of gingival tissue, gingival hypertrophy. So it's also important to realize, what I like to tell my patients is that this is not a manifestation of an infection. This is just extra volume. This is extra volume tissue. And it can be believed to be it may lead to a condition called periodontal disease or gum disease. And what gum disease, this is a schemata of what gum disease is. On the far left, you see healthy gums. So you can see the gingiva looks relatively healthy. It's red. It's good shape, good size. But here on the right, you can see some shrinkage of the soft tissue, some redness, perhaps some extra volume. And a condition like this is known to be the leading cause of tooth loss in patients who are 40 years or older. And it has been studied whether there is an association between gum disease and patients with acromegaly. And according to this article, it was observed that patients with acromegaly do not present with periodontitis. In other words, they do not present with gum disease. They're not at risk for gum disease. And that extra gingival tissue is just a variation of normal. And now we're going to move on to craniofacial features.
Thank you, Dr. Alhaji. So this is actually another extract from the acromegaly slides. This is a radiographic image of a lateral cephalometric profile view. What you're seeing here is basically cranium features of frontal bossing. So the sinuses within our cranium are there to basically alleviate and make sure that our skull isn't too heavy, encompassing our brain. The frontal bossing is a feature on the right, and as you see on the left, the arrow points to a enlarged cella turcica, which houses, as we saw in the prior talk, the hypophyseal gland, which is where these adenomas grow. What you're noticing also is that the paranasal sinuses, which are below these yellow arrows, are also increased in size. And so the whole base of skull craniofacial features of the cranium are not only accompanied by maxillary mandibular overgrowth. What you're seeing is that protrusion, which is known as prognathism, as well as features of temporomandibular joint disorder, which are the ones that you see underneath the circle. Next slide. Usually in maxillofacial surgery, we try and keep our incisions within the realm of the oral cavity. We like to avoid cosmetic defects and extraoral incision if possible and hide everything intraorally. So we use mucosal incisions. We are able to deglove pretty much the whole face by accessing our maxillary upper jaw and mandible lower jaw, and then eventually move the bones in space once the bony cuts and osteotomies are created. And that's what's depicted on the right. Next slide. The tori that we mentioned before are essentially in the upper jaw, which is on the prior slide. So what you're looking at on the prior slide is basically a torus, and that torus maxillaris is basically like a walnut or a half shell walnut in the upper jaw, can impede the seating of your denture. And on the lower jaw, you have the same similar picture towards the tongue side, which are bony exostosis, benign appositions of overgrowth of bone, which are pea-sized areas. This also gets degloved and can be done either awake or asleep under local anesthesia, depending on patient tolerance. If obviously you need to start bringing out chisels and osteotomes, in other words, burrs and bone files to recontour, it's sometimes best to be asleep in the operating room. Next slide, please. These exostosis also appear on the cheek sides. What you're noticing here is that this is a lower jaw with no teeth. It's an edentulous mandible. Again, this degloving mucoperiosteal flap approach, which maintains everything within the mouth. And the buccal exostosis are then reduced using, again, bone files or chisels. Besides these, you can do some simple gingivectomies or gingivoplasties for the hypertrophic gum lines to prevent down the line possible issues with periodontal infections. And now to go on to facial proportions, when we actually evaluate these patients, what we're looking at is something known as the golden rule in plastic surgery. We like to say that an ideal, which is of course a subjective norm, and this is always race-based, of a face proportion would be twice the height for the width. What you're seeing here are the facial fifths in the vertical dimension and the facial thirds in the horizontal dimension. We also look at patients from a side view. So on the next slide, what you'll see is that we actually look at angles. We look at the angle between the forehead and the nose, between the nose and the upper lip and lower lip and chin and neck. This tells us what the type of patient face is, if it's actually a straight face, a convex face, so a face that's like this, or a face that's concave. And we always work now in the last 15, 20 years with something known as virtual surgical planning, which is what you'll see on the next slide. Basically, the patient's imaging of the computerized CAT scan. So his computerized assisted tomography, which is the CT that you're seeing, gets a 3D rendering. This 3D rendering gets sent to a company which enables us to do virtual surgical planning, which is abbreviated with VSP. And from the comfort of our office, we can actually already do the cuts in space. We can move the bones. We can even go as far as having splints made, which used to be made by the residents in the lab on a Sunday before a case on the Monday. And these basically get spit out by a computerized assisted design and manufacturing process. And as you see in the right image, even the plating system is something that we can then obtain, sterilize it, and bring it to the operating room. Obviously, this decreases operating room time and hence patient morbidity. The final feature is finally orthognathic surgery. What you're seeing here is a before and after picture, a young female with a very convex face, retrognathic jaw, the opposite of an acromegaly patient, but nevertheless has a very long face. And what you're noticing here is that by moving Humpty Dumpty and putting them back together again, these jigsaw puzzle pieces can then be moved in space forward as well as impacted upwards or downwards to create that more quote unquote aesthetic, balanced visual appearance. So this brings us to the temporomandibular joint, which with the advancement of the prognathic jaw, lower jaw, has issues with the interocclusal interdigitation of teeth, because teeth like to be balanced, as Dr. Alhaji mentioned, in a bite or an occlusion. The temporomandibular joint is sort of like a shoulder joint or like a hip joint. It's basically a ball and socket mechanism, has discs, has soft tissue, which are also muscles holding it in place at the base of your skull, is really responsible for a rotation move and a translation move, which enables you to open and close your jaw. Now, patients usually complain of pain in front of the ear, which is clicking or popping or noises or little grinding sounds when they open and close, with extremes of maybe even having problems opening or closing their jaw, known as locks. So what are the treatments for the TMD or temporomandibular joint issues or diseases or disorders? Initially, you want to try conservative management, pain management, physical therapy, and splints that are custom made. This prevents the patient from grinding or bruxing, and obviously takes the load of the forces off the temporomandibular joint. Of course, if this fails, you have to move on to the next step, which is basically surgery. Surgery creates scars. We work in a very small space. The access is basically preauricular. We then go to the extraoral with extensions into the scalp, and if needed, can actually have again a CAD camera, computerized, assisted, designed, prosthetic made, just sort of like a total hip joint replacement or a total knee joint replacement. Brings us then to obstructive sleep apnea, which is really the topic of our next speaker, but I just wanted to go over a bit of the anatomy. So nasal passages enable air entrance as well as the oral cavity. The blue line shows you exactly where the air ideally should pass in normal breathing. What you're seeing on a profile view here is when you have snoring or partial obstruction, you can have redundancy of soft tissues. And now we're talking about the soft tissue redundancy of acromegaly, with obviously increase in size in tonsils or adenoids or just uvula or palatal structures. Even the tongue, which is macroglossic, when you recline, gets thrust posteriorly, and that can then completely obstruct your airway. We like to divide the airway in 3 zones. And then we obviously do this in a multidisciplinary fashion. We analyze these patients and work them up with our ear, nose, and throat ENT colleagues. And that brings us to the next slide, which is actually the workup, where we do a volumetric analysis of the 3 different levels of the airway: the nasopharynx, the oropharynx, and the hypopharynx. And this is what you're seeing in yellow. Again, we resort to these lateral views, these profile views, where we then decide how to move the facial drape based on the movements that we're going to impart on the upper jaw or the lower jaw, so that we can thrust that tongue forward, so that when the patient is sleeping, the tongue doesn't prolapse posteriorly. So on the next slide, what you're seeing is a basic conservative management. Again, sometimes the anatomy variation is such that you can just use CPAP, continuous positive airway pressure, which is basically a device that you're going to wear at night to sleep, which insufflates posterior positive airway pressure in order to open that redundancy of soft tissue. And sometimes you can have a dentist, which is what you're seeing on the right side, create something known as this appliance, an oral appliance, which is basically prognathic, bringing your lower jaw forward so that your tongue can be thrusted anteriorly so that it doesn't prolapse posteriorly while you're sleeping. If that fails, obviously we also resort to surgery and have to proceed to something which is a bit more aggressive, which is known as a bimax advancement or a maxillomandibular advancement, which is a full 10 millimeter or 1 full centimeter advancement of the upper and lower jaw, so that we can then move all those soft tissue redundant structures anteriorly or forward. Brings me just to a concept of many moons ago. I met my husband in Canada, and he's also a neurosurgeon. And of course, when we were dating, we watched transphenoidal videos. And at the time, the approach was sublabial, which from what I understand is classically the original historic approach, but now it's transnasal. Interestingly, it's brought me to the concept of, well, what are the complications of these type of approaches? And what you'll see is that in certain articles from Asia, patients have complained of, if you look at the next slides, basically 2 articles that mention either stenosis or scarring in the areas of the approach. And you saw that we deglove patients through the mouth. So you can imagine how those scar tissues will impede the seating of a denture after that type of surgery. As well as some of the patients also have issues with nasal passage stenosis and intake of air, as you saw in the profile view in the obstructive sleep apnea slide. Finally, a lot of patients have issues with numbness postoperatively, and that numbness can become a problem because it impedes speech, it impedes motion, it impedes the sensation of having that denture in place. And so basically they have dysesthesia as pain can also be a problem after this type of surgery because of scar feature. So in conclusion,
we can see that these oral manifestations that we highlighted during this presentation today can actually be present for up to 10 years before an official diagnosis, and that the majority of our patients actually present with these oral manifestations of up to 80%. And they can often be the first sign and symptom for an indication for this condition. And obviously early diagnosis can significantly improve quality of life. In a nutshell, early diagnosis can actually lead to a reversibility of these features. And it takes a village. It takes a village to be able to diagnose and manage these conditions. We operate out of two clinics in New York City, the first one being the Oral Health Center for People with Disabilities within the NYU College of Dentistry. And we also operate at a dental faculty practice within the ambulatory care center. These are some extra resources, and if anyone has any questions, this is our information, our emails, and our number. Thank you.
Thank you so much, Vivian and Dalal. That was extremely informative. Thank you very much. And, really tells us that we probably should be doing much more, perhaps even going up to the American Dental Association and talking more about screening tools in these patients. So thank you for that presentation. We have our next speaker, that is Dr. Francesca Dassi. Dr. Dassi is an endocrinologist from the University of Padua in Italy, and she's a current research fellow in the Department of Endocrinology and Rare Diseases. Dr. Dassi has published extensively as a pituitary endocrinologist on several different aspects of acromegaly, especially cardiovascular health, arthropathy, cognitive changes, and as you just heard, she's really kind of the world leader when it comes to obstructive sleep apnea and acromegaly. Dr. Dassi is logging on all the way from Italy. Thank you so much, Francesca, for being here.
Thank you, Nidhi. Good afternoon. It's a pleasure for me being here today. I would like to thank the organizing committee inviting me. My talk today will be focused on sleep apnea and acromegaly. Sorry, I have to stop my video because my connection doesn't work very well today. So I start with my presentation. Did you?
Yeah, we can see your slides.
Okay, thank you. As you know, acromegaly is a systemic disease because growth hormone and IGF-1 receptor are ubiquitously expressed, and the deleterious effect of both IGF-1 and growth hormone excess manifest in multiple organ systems. The more frequent complications in acromegaly are the cardiovascular ones, followed by the metabolic and the endocrinological comorbidities. Regarding respiratory manifestation of acromegaly, as you can see from this slide, approximately 1/3 of acromegaly patients has a respiratory complication. The main respiratory complications are the obstructive sleep apnea, which has a prevalence that spans between 27, 80%. The central form of sleep apnea that can be also present in up to 30% of patients. And finally, there is the respiratory insufficiency that is present in 30, 80% of patients. The last one, the respiratory insufficiency, is the less studied compared to sleep apnea, and it's characterized by an increased lung volume, a reduced lung distensibility, and a reduced thoracic and muscular forces that determined a decreased oxygen level in the blood. These are data about the frequency of obstructive sleep apnea in acromegaly in different countries. This data come from acromegaly registries from all over the world. And as you can see here, the majority of the states considered in this beautiful paper had no differences about the epidemiology of this pathological condition. Sleep apnea, obstructive sleep apnea, is more frequent in acromegaly patients compared to the general population. Defining OSA, to define obstructive sleep apnea, we can say that obstructive sleep apnea is the most common sleep-related breathing disorder in acromegaly. And you see the definition of my slide, but to summarize, we can say that when you have an apnea, you repeatedly stop and start breathing while you sleep. While if you have hypopnea, the total amount of air reaching your lungs is limited. Central sleep apnea differs from obstructive form because in this case, your brain doesn't send a proper signal to the muscle that control your breathing. I remind you that in acromegaly, the obstructive form is the most frequent type of sleep apnea. As you see in the previous presentation, obstructive sleep apnea is the more frequent form in acromegaly patient because growth hormone and IGF-1 excess induce some specific anatomical. Oh, sorry. Let me. It's sorry. It's for the. Okay. So, acromegaly induces some specific anatomical changes affecting facial bones and soft tissue with the increased presence of nasal polyps and increased volume of tongue, macroglossia, and uvula, as you can see in this picture of one of my patients. There is also an increase in size of mandible and maxilla and a well-known modification of voice. In this audio, I try to restart the audio. Okay. You can appreciate the voice of Lionel Rivero, one of the most famous Argentinian tango singer, that had a deep bass baritone voice due to his GH excess, so due to his acromegaly, instead of a tenor type of voice that is the most frequent type of voice in tango singer. Moreover, there are some modifications also in the lower respiratory tract, where you can find an increased volume of larynx that may be associated with tracheal stenosis. And finally, all these changes cause an hypopharyngeal swelling with an inspiratory collapse. In this slide, the gentleman on my left is affected by a pituitary adenoma GH growth hormone secreting, while no one doubts that the lady on the right is not affected by a GH-related disorder. Why does the patient on the left have a greater risk of OSA compared to the lady on the right? Because, as you can see in this figure of that depicted a magnetic resonance of an acromegaly patient compared to those of a patient not affected by GH excess, the part highlighted in red that represent the pharyngeal area is lesser in the acromegaly patient. And in addition, the nasal cavity contains a more evident black area, which means more air in the lady nose compared to the man here on the right. So, obstructive apnea occurs when the muscle in the back of your throat relax too much to allow normal breathing. When the muscles relax, your airways closes as you breathe in, hampering your breathing for 10 seconds or longer. This can lower the level of oxygen and cause a build-up of carbon dioxide. Your brain senses this impaired breathing and briefly rouses you from sleep so that you can reopen your airway. This awakening is usually so brief that you don't remember it. You can awaken with the shortness of breath that corrects itself quickly within 1 or 2 deep breaths. You might make a gasping sound. This pattern can repeat itself up to 30 times each hour, all night long. This disruption impairs your ability to reach the deep, restful phase of sleep, and you probably felt sleepy during your waking hours. In the figure, these phases of apnea are depicted. Other mechanisms involved in acromegaly sleep apnea are those related with the central sleep apnea. Few studies have investigated this aspect in acromegaly. What is known is that GH excess may cause an increased sensitivity to peripheral stimuli with a reduced control on neuronal mechanism. More studies are needed to explain the mechanism under the central sleep apnea condition in acromegaly. In order to understand the importance of sleep apnea in acromegaly, I have to tell you that the sleep apnea symptoms. Symptoms of obstructive sleep apnea may include loud snoring, abrupt awakenings accompanied by gasping or choking, observed episodes of stopped breathing during sleep, excessive daytime sleepiness, also for the patient's partner with morning headache, difficulty concentrating during the day, fatigue, mood changes such as depression or irritability. You have to consider that among acromegaly symptoms at diagnosis, 25% of patients complain snoring and 15% of patient tiredness, which can complicate obstructive sleep apnea screening and diagnosis. Due to obstructive sleep apnea systemic complication, the sleep apnea in acromegaly and also in the general population is considered a serious medical condition. Complications of sleep apnea can include neurocognitive complications such as depression, cognitive dysfunction, and ischemic disease, daytime fatigue and sleepiness. Because of a lack of restorative sleep at night, patients may have impaired working skill, and this can put them at higher risk of work-related accident or car accident. Sleep apnea also exacerbates insulin resistance and diabetes that are among the most frequent complications in acromegaly too. This is also the case of cardiovascular problems. Sudden drops in blood oxygen level that occur during obstructive sleep apnea increase blood pressure and strain the cardiovascular system. That is affected also by GH excess. Many people with obstructive sleep apnea developed high blood pressure, hypertension, which can increase the risk of heart disease. The more severe the obstructive sleep apnea is, the greater the risk of coronary artery disease, heart attacks, heart failure, and arrhythmia is. If there is underlying severe heart disease, this repeated multiple episodes of arrhythmias could lead to sudden death. Obstructive sleep apnea has an increased mortality, and symptoms and complications have an important economic burden on society. So, obstructive sleep apnea is severe, may worsen acromegaly complication. Several studies have demonstrated that obstructive sleep apnea in acromegaly patients is already present 3 years before the diagnosis of acromegaly. And in approximately 1% of acromegaly diagnosis of acromegaly is due to obstructive sleep apnea diagnostic workup. At acromegaly diagnosis, the prevalence of obstructive sleep apnea is double in recently years because diagnostic techniques are improved and we raise the awareness about this important issue in acromegaly patients. Among the risk factors for sleep apnea development in acromegaly patients, there are disease activity, early age, neck circumferences, and male gender. According to this data, the last guideline on acromegaly complications suggests that your doctor have to exclude sleep apnea at acromegaly diagnosis. So every patient should undergo careful assessment for sleep apnea at diagnosis of acromegaly. This assessment must include a throughout history, questioning of partner about snoring, about pause on your breath, and the potentially use of a sleep questionnaire such as the Epworth Sleepiness Scale. This is the Epworth Scale, often used clinically to screen for the manifestation of behavioral morbidity associated to sleep apnea. The Epworth is a self-administered questionnaire with 8 questions. Respondents are asked to rate on a 4-point scale, and it can range between 0 to 24. If you have more than 10 points, your daytime sleepiness is considered excessive and you have to consult your doctor. In this, if obstructive sleep apnea is suspected, you have to do a polysomnography to confirm or rule out the sleep apnea. In our clinic, we use an at-home version of polysomnography that provides us data about airflow, breathing partner, blood oxygen levels, and snoring intensity. In the video, you can see our nurses, Carla and Mariangela, showing how to place the polysomnography in our patient. With this test, we are able to count, I move on the video, we are able to count the number of apnea and hypopnea, and we are able to stage the severity of your sleep apnea. In acromegaly patients, this exam has to be done before initial acromegaly surgery. In fact, in patients with sleep apnea and severe increase of pharyngeal swelling, is recommended a preoperative medical treatment with the somatostatin analog in acromegaly guideline. In order to make more comfortable intubation, because effective treatment of acromegaly with reduction of GH and IGF-1 levels and concomitant reduction in soft tissue swelling may significantly improve sleep apnea. So, in this slide, you see on the left the machine to perform the at-home test, and on the right how the machine look like after positioning in our patient. Medical and surgical treatment of acromegaly dramatically decrease apnea and hypopnea index. Nevertheless, because sleep apnea may persist or worsen despite appropriate acromegaly therapy, post-treatment evaluation is essential and regular monitoring recommended. As you can see from the graph, during treatment, there are a reduction of acromegaly patients with OSA and a reduction of sleep apnea severity. If sleep apnea persists or worsens despite appropriate acromegaly treatment, post-treatment evaluation is essential and regular monitoring recommended in our patient. Continuous positive airway pressure with a specifically fitted mask may be necessary for patients with a typical facial morphometry resulting from acromegaly. In this treatment, a machine delivers air pressure throughout a piece that fits into your nose or is placed over your nose and mouth, and you can see from the figure. Positive airway pressure reduces the number of respiratory events that occurs as you sleep, reducing daytime sleepiness and improving your quality of life. Other treatment are of sleep apnea are the weight loss or the using a lateral sleep position, and in selected case, as you remember from the previous presentation, we can also consider surgical treatment. Remember that management of sleep apnea patient in acromegaly patients should be multidisciplinary. In this paper, authors show that the practice use of continuous positive pressure of CPAP after transphalangeal surgery for pituitary adenoma was not related to other comorbidities, so it can be used also after neurosurgery. To conclude my presentation, so it's important that an early acromegaly diagnosis may prevent anatomical changes that are the main causes of acromegaly sleep apnea. Obstructive sleep apnea can make other acromegaly-related complications worse. Diagnosis of obstructive sleep apnea is mandatory to prevent surgical treatment complication and to reduce mortality in acromegaly patients. Obstructive sleep apnea can persist after acromegaly treatment, and a long-term follow-up of sleep apnea is necessary. To finish my presentation, I want to share with you some picture of the university and the University Hospital of Padua. Our motto, our university motto is Universa Universis Patavina Libertas. That means that university liberty is our main task. We are one of the oldest university in the world. We had the first botanical garden, the first permanent anatomical theater, and the first woman alumna, Elena Lucrezia Cornaro, that received a degree in philosophy. These are my words. I work every day in an internal medicine ward that had a high intensity unity and an important outpatient service composed by a day service with 4 beds, the possibility to perform echocardiographic and ultrasound diagnostics, and we can also manage all the lab tests to do diagnosis and follow up of all endocrinological conditions. On the right, you can see also a poster of Italian Pituitary Disorder Association. And so thank you for your attention.
Thank you, Dr. Dassi, for a really great presentation. Thank you so much. We are now going to take a short break, and we'll also try and answer some questions that we received in the chat over the last couple of hours. And of course, if you have any other questions, please continue to use the Q&A function to put those questions in.
I think, Nidhi, there was a question that had come up before on the effect of COVID. It's in the Q&A on the answered section. So
yes.
Yeah.
Yes, thank you. So, we are actually going to wait to answer that question, Dr. Kofinos, because we have a speaker who's speaking specifically on COVID-19 changes in acromegaly. So we'll bring that question up again during the second break. There have been some questions talking about a delay in diagnosis. And, of course, unfortunately, we do see that with acromegaly. And, as we were saying before, really, I think disease awareness is key. We really need to do, at least as medical professionals, I can speak for myself, we have to do a better job at going into the community, talking to other providers, perhaps even educating and empowering our patients to make sure that they understand what the manifestations are, and perhaps even ask for screening if there is enough evidence. But yes, I do see some of your questions talking about a delay in diagnosis, and it's extremely unfortunate, but I do think that we need to do more as medical providers to avoid that. There was also a question about the presentation being recorded, and yes, you will have a recording of all the talks. It's going to be recorded and available to all the registrants. I have a question for Dr. Vasmur-Parod and also for Dr. Al-Haji if they're still available. And it's mostly just to ask and just kind of educate myself about if there is any guidance from the American Dental Association on screening for acromegaly or not yet.
So it's interesting because we looked it up and there's actually not much literature. There's actually none. So if you think of the prevalence and incidence, we rarely see an acromegaly patient. But thinking back, and thank you for inviting us to present, a lot of patients come in with the complaint of ill-fitting prosthetics and increase in size of buccal bone and palatal bone and lingual bone. So I think definitely there is a motion that we should consider making for the American Dental Association. Absolutely. As well as our, ABOMS, Oral and Maxillofacial Surgery Association.
Thank you. Dr. Dassi, do you have something similar in your country as well?
In Italy, we have a problem because all the facial manifestation and all the dentistry complication of acromegaly are not they are not included into the common practice of acromegaly patients. So the national health system did not permit us to the reimbursability of the dentistry treatment for sleep apnea or for the manifestation, for the odontoiatric manifestation. We collaborate with our dentists in our hospital, but is a unique example in Italy for acromegaly patient.
Thank you. Thank you, Francesca. We have a few more questions on the chat. So the first one is, I have a recurrence of lipomas normally on my back, and I've had 3 large ones removed, and notice I have another one on my back. Is this related to acromegaly? And of course, if someone else wants to weigh in as well, but I will mention, so, as we all know, growth hormone is an anabolic factor. It does lead to proliferation of tissues, specifically for soft tissue swelling. But, in relation to lipomas, I don't think it's very clear if it specifically leads to increase in the size of lipomas. Of course, we can see skin tags, we can see more acne, we can see more sebaceous gland production and more sweating, and there is pathophysiology behind that. But specifically for lipomas, I'm not aware. Dr. Dassi, do you want to add to that?
I confirm what you say. There are no study on that determine that GH excess may cause a larger lipoma. There are association with skin task, but I don't know. I don't remember study that noticed this fact. Yeah.
There's another question on the chat. Is normal range of IGF-1 different depending on the lab where you do the test? I used to do the test with Stanford and then switch to Quest. So this is actually a really important point that someone's brought up, and it has to do with assays in both growth hormone and IGF-1, but it's really more for IGF-1. And there is very nice studies which show how immunoassays, which are different from LCMS, which is mass spec assays. So immunoassays really do have a wide variation and variability, unfortunately. It is not so much for the lower end of normal, but more for the upper end. And there are nice studies, mostly coming from France, which have looked into that. So what we are recommending to most patients is that if you were to choose a particular lab, try and stick to the same lab when you follow up, even, with your endocrinologist. So for example, if it's an immunoassay, then just continue doing the immunoassay every time during surveillance. If it's LCMS, which at least in the US, Quest offers LCMS techniques. So if you're going to a Quest lab, try and stick to the Quest lab each time, both during diagnosis and surveillance. But that's an excellent point. There is indeed a difference, when you look at the different assays. There is also another question about facial changes. And it says, my growth hormone was high over the range and IGF-1 has been elevating over the range, but suddenly my growth hormone came back lower under the range. What could be the cause and how to do an OGTT if my growth hormone is low? What could be the cause of a lower growth hormone and what to do about it to get the diagnosis? So, this actually gets to the whole crux of discrepancies between IGF-1 and growth hormone levels. And unfortunately, we do see those. Of course, Francesca, feel free to chime in as well. But, I can tell you that in women, the IGF-1 levels are going to be lower. And that's because of the protective effect of estrogen at the level of the liver. In men, testosterone has the opposite effect. IGF-1 levels can be much lower in times of starvation, poorly controlled diabetes, as an example, and is going to be falsely elevated if the patient is going through puberty, pregnancy. Those can give you falsely elevated levels. After treatment, there can be some discrepancy in patients who are already on treatment with somatostatin receptor analogs as well. Not sure if that answers your question, but Dr. Dassi, do you want to add anything to that?
Yeah, I think in this case, it's also important to determine how IGF-1 level is increased.
Oh, I think you're on mute,
because,
Francesca.
oh, do you hear me?
Yes.
Yeah. Okay, in this case, I think that also the how much the IGF-1 is increased upper the limit of normal is important. And we have a lot of cases like this with the discrepancy between GH level, as you see before, and IGF-1 level. I think that this is one of the cases in which we use different assay to determine if there is a real IGF-1 increased level or not. I suggest to go on with follow-up and to determine if why IGF-1 is increased. And also I confirm your hypothesis, the age, the menopausal states for women. So very, 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 there are some important aspects to consider in this case.
Great. Thank you so much. We will take a short break of 5 minutes, and then we're going to reconvene at 9:45 Eastern Time. And that's going to be to talk about medical therapy and novel treatment options in acromegaly. I really wanted to thank all the speakers again. Thank you for sharing your Saturday morning with us. I know it's not easy, but thank you so much for being here. And we will come back in 5 minutes. Thank you. All right, so we will go ahead and get started with the next part of this session today, which is going to focus on management and acromegaly. I'm going to start with medical management of acromegaly. Following my talk, there will be a talk by Dr. Golfinos and Dr. Konzioka on surgery and radiotherapy in acromegaly. And then, of course, we have a talk on acromegaly and the implications of COVID-19 following that. And of course, thank you again to all our speakers, and thank you for all the attendees and their questions, and please keep them coming. Okay, so treatment goals in acromegaly. So as we've seen in the last few presentations, really the goal is to remove or reduce and control the pituitary tumor as much as possible. As we control the pituitary tumor, we are effectively removing the effects of growth hormone excess, and IGF-1 is better controlled. We also want to try and preserve the pituitary function during surgery. And then relieving the symptoms and signs of acromegaly is, of course, the leading goal. The first line of therapy in patients with acromegaly has always been surgery. And of course, you really do want to go to a wonderful surgeon. We are very blessed here at NYU to have the best surgical expertise probably in the country at this point. You want to go to a high volume pituitary center. You want to make sure that your pituitary surgeon is high volume, kind of doing a lot of these pituitary surgeries every single year. Medications is a close second line of management with acromegaly. And then, of course, in recalcitrant cases or in addition to medications, we can also use radiation therapy. So the surgical remission rates, according to the literature, in larger tumors, which are tumors more than 1 centimeter, the success rate has been between 50 and 75% in the literature. With smaller tumors, which are better enclosed and not moving sideways into the cavernous sinus, which we spoke about earlier, that success rate is higher at 70 to 80%. And the primary predictors of good surgical remission are the pre-op growth hormone levels. We know that if the growth hormone is higher before surgery, then the surgeon might not be able to remove the entire tumor completely. Larger tumors are harder to remove. And cavernous sinus invasion, which means invasion into the sides of the pituitary, can also be very challenging for the surgeons. Radiation therapy controls tumor at 50 to 60% at 5 years, and then almost at 80% at 10 years. So what are the indications for medical therapy? Persistent disease following pituitary surgery for acromegaly. We very rarely use it for pre-operative use, and this, of course, has to be done on a case-to-case basis. We have sometimes used it in patients with very severe obstructive sleep apnea, a lot of soft tissue swelling, where intubation can be challenging, but this is not the standard of care at this point. We can also use medications post-radiation as bridging treatment because radiation takes years to take effect. And of course, we can do it as patient preference or patients who are high risk for surgery. So this is a timeline of all the FDA-approved medications in the United States so far. We know that octreotide has been approved by the FDA for use. In 2003, pegvisomant, which is a growth hormone receptor antagonist, was also approved. 2007, we had our second somatostatin receptor analog, which is lanreotide, which was approved. In 2014, pasireotide, which is a second generation somatostatin receptor analog, was approved. And then finally, of course, it's a very exciting time because in 2020, we had the first oral formulation of octreotide, which was approved as well. There is an off-label use of cabergoline, which you might have seen many different practitioners talk about cabergoline, use cabergoline, but this is not FDA approved. So with medical treatment options, I see the overall goals of treatment as normalizing growth hormone and IGF-1 level, but it's really extremely challenging because it all depends on where the medications are acting. So at the level of the tumor itself, or at the level of the pituitary itself, we have somatostatin receptor ligands, dopamine agonists like cabergoline, which can act at that level. And radiation therapy, if we do require radiation, is also at the level of the tumor control. Growth hormone receptor antagonist, on the other hand, of course, acts peripherally. So that is going to help to reduce the effects of growth hormone and IGF-1 in the peripheral tissues. So moving to the first class of medicines, which is somatostatin receptor ligands, also called SRL, you can see that there are different receptors which are present on the growth hormone secreting tumors. These are called somatostatin, also called SST. So there are many different kinds of receptors, as you see here, from 1 to 5, and there are different medications which bind to different somatostatin receptors. As an example, the first generation somatostatin receptor ligands, which are lanreotide and octreotide, bind more specifically to SST2 or somatostatin type 2. And the second generation somatostatin receptor ligand, which is pasireotide, can actually bind to multiple different somatostatin receptors, but preferentially to something called SST5, as you can see in this diagram. These are some pictures of the medications and kind of how they look. I think a lot of you are very familiar with these medications. The first one is octreotide LAR. It's an intramuscular injection, comes in different doses, 10 to 40 milligrams given every 4 weeks. As you can see from this image, it's an intramuscular needle, so it goes all the way down into the muscle, and this has to be reconstituted. So it has a diluent and a powder. Lanreotide autogel is a deep subcutaneous injection, comes in different doses of 60 to 120 milligrams sub-Q, and it's usually given every 4 weeks. And this is actually a pre-filled syringe of autogel. Pasireotide, long-acting preparation, is also an intramuscular injection, comes in different doses given every 4 weeks. And oral octreotide, of course, which is the newest kid on the block, is it's a capsule, and it comes in 20 milligrams capsule, and you can use up to 40 to 80 milligrams PO daily. So moving on to somatostatin receptor ligands, which in my mind is usually the first line of therapy. And why is that? It really has good tumor volume reduction. So 50 to 75% tumor volume reduction. This is mostly because it acts at the level of the pituitary tumor. It's going to reduce proliferation of the gland. It's also going to lead to apoptosis or death of some of these cells, and that's how it controls tumor growth. IGF-1 and growth hormone normalization may occur in 30 to 55%. So it's not fantastic, and I wish these numbers were higher, but it's definitely quite effective as first-line therapy. The side effects could be gallstones because it can cause sluggish gastric motility and some sludge, diarrhea, bloating, and bradycardia. These are the studies which I've summarized here, which actually looked at the rates of normalization of IGF-1 with first-generation somatostatin receptor analogs. And like we were saying before, it's approximately 30 to 55%. What about second-generation somatostatin receptor analogs? So the most prominent one, actually the only one that we know of, is pasireotide. This was approved in 2014. And it's a multi-receptor targeted ligand, specifically with action on SSTR5. The side effects are very similar to the first generation somatostatin receptor analogs, but in addition, it also causes hyperglycemia, which we'll talk about in the next slide. There was a head-to-head trial of pasireotide, which is the second generation somatostatin receptor analog, with the first generation somatostatin receptor analogs, which is famously called the Paola study. And there is evidence to suggest that pasireotide could actually be a little bit more effective in biochemical control, also seen in extension studies of up to 5.5 years. I think one of the limitations and something that concerns some endocrinologists with pasireotide may be the risk of hyperglycemia, although as I'll just discuss in the next slide, we are getting a little more comfortable even with management of hyperglycemia with pasireotide. So why does pasireotide specifically cause hyperglycemia? So it's actually because of the effect on the pancreas. So the pancreas have the alpha cells, which make a hormone called glucagon, and it has the beta cells, which makes a hormone called insulin. Specifically, SSTR5, which is the somatostatin that pasireotide is acting on, blocks insulin production and hence leads to hyperglycemia. Pasireotide also blocks somatostatin receptor 5 in the gut, and there is something called incretins, which helps to increase insulin response, and this is unfortunately reduced by pasireotide. So pasireotide leads to reduction in insulin and also reduction in incretins, which ultimately leads to hyperglycemia. The risk factors of hyperglycemia with the use of pasireotide are if the patient has diabetes or impaired glucose tolerance at baseline, patients who already have hypertension, hyperlipidemia, or are obese. And the studies have shown that up to 42% of patients can have hyperglycemia, and new onset diabetes can be present in up to a third. Metformin is a nice medication to consider in patients who do have hyperglycemia. You can also talk about DPP-4 inhibitors like Januvia. And then, of course, GLP-1 agonists are very, very effective medications because the problem here is a reduced incretin response. And with the help of a GLP-1 agonist, we are indeed reversing that. There was a recent study just published last year by Dr. Sampson, and she actually demonstrated that as acromegaly improved, 50% of patients with acromegaly actually did not develop hyperglycemia despite being on pasireotide. So this is indeed a very effective medication. We are finding out more and more about better management tools with hyperglycemia. And so it should be used, especially in patients with aggressive tumors or with tumors which are not responding to the first generation somatostatin receptor analogs. What about cabergoline? So cabergoline, I think a lot of you know about cabergoline because it's a very commonly used medication in prolactinomas. In prolactinomas, the doses that we use are much lower than the doses that we use in acromegaly. This is a long-acting oral dopamine agonist, and it is not usually used as first line of treatment, especially in aggressive pituitary adenoma secreting growth hormone, but it can definitely be used as add-on therapy. So I do have some patients where we've added on cabergoline to say somatostatin receptor analogs, and it helps, especially with the co-secreting pituitary tumors. There are higher doses which are required for better control of IGF-1 and growth hormone, up to 2.5 to 5 milligrams weekly. And studies have shown that just with cabergoline alone, there's a 30% IGF-1 control, but when it's added on to different medications, specifically to somatostatin receptor analog, that number could be higher at 50%. So moving on to pegvisomant, which is the growth hormone receptor antagonist. The studies have shown that there is approximately a 60 to 70% control. So really excellent control of growth hormone and IGF-1 levels. And this is in contrast to the lower control that you're seeing with somatostatin receptor analogs and cabergoline. So it's a very effective medication. We do not follow IGF-1 levels with pegvisomant. We do not follow growth hormone levels with pegvisomant. We follow IGF-1 levels because this is a growth hormone receptor antagonist. We know that as opposed to pasireotide, this medicine can actually improve hyperglycemia, and that's because it improves insulin sensitivity. And the side effects are elevated liver enzymes. So anyone who started on this medication needs their LFTs checked at baseline and then frequently thereafter. There can be injection site reactions in 3 to 4%. And tumor growth, so at the level of the pituitary, approximately 3 to 7% patients can have tumor growth. So this should be monitored as well. These are the studies that have looked at pegvisomant, and as you can see here, pretty good efficacy of the medication. But you do want to reserve these for patients with aggressive disease, young age at diagnosis, higher IGF-1 concentrations. Think about this for acromegaly with diabetes because we know that the insulin resistance is improved with this medication. I've also used this medication as add-on therapy and as combination therapy because I feel like it acts really well when done like that. So just as a summary, this table just goes over what we discussed. So somatostatin receptor ligands, 30 to 50% control, a little bit better tumor control with pasireotide. But of course, the side effects of hyperglycemia, which we are managing better and better these days, have to be kept in mind. 60 to 70% efficacy with pegvisomant. There is a small chance of increase in the tumor growth, 3 to 7%. And of course, these are the side effects, injection site reactions, and the liver enzymes may be elevated. And cabergoline, really probably not as effective as first-line treatment, but can be very, very useful as add-on therapy, especially for post-secreting tumors. So combination treatment in acromegaly is, I think, extremely popular these days. It helps us personalize treatment. It helps to customize treatment according to what the patient needs. And we do know that anyone with cabergoline plus somatostatin receptor analog can have up to 30 to 50% control. Pegvisomant plus somatostatin receptor analog can be excellent at 80% control. So it really, really does help with that biochemical control that we are looking for. There are newer studies now which have looked into combining Somavert or Pegvisomant to somatostatin receptor analogs just to reduce the cost and also to improve the overall efficacy, because Pegvisomant can be a little expensive at $100 for every 10 ml. So to do it as a combination drug, instead of taking it daily, you could actually do weekly Pegvisomant treatment too. So let's go over some new medications and what's in the pipeline. And of course, first we have to mention the newest FDA-approved medication in 2020, which was oral octreotide or Mycapssa. Really a wonderful technology. And why is this so exciting? So we know that oral octreotide is a peptide, and all peptides get degraded by gastric enzymes and also by a lower pH of the stomach. The reason this particular medication is interesting is because it has an enteric coating which protects it from that gastric pH so that it can come nicely intact into the intestine to get absorbed. There is a very smart mechanism that this company used, which is called TPE or transient permeability enhancer, which basically allows the medication to reach intact into the gut without getting degraded into the stomach. And then it also helps with transient opening of these particular intestinal junctions so that the medication can nicely come into the bloodstream. So I'll go over this picture in a little more detail. So this is the peptide, which is octreotide. You can see the enteric coating, and of course with TPE enhancers, which are basically medium chain fatty acids stabilizing the molecule. The patient takes the pill. It will help avoid degradation in the stomach because of the enteric coating, and then it reaches the intestine. And as you can see here, these tight junctions in the intestinal cells are going to open up with the help of TPE, which is transient permeability enhancer, and that's what leads to the absorption in the bloodstream. So really exciting advancement here. There are many studies that have led to the approval of oral octreotide. I'm not going to go into details here, but the two major studies were Chiasma Optimal and Empowered, and it was the Chiasma Optimal study which led to the approval of this particular drug. 58% of patients taking oral octreotide actually maintained their IGF-1 levels in response, compared with 19% of placebo at the end of 9 months in that study. And we know that we can start at 20 milligram capsules, usually twice per day, and they're taken 1 hour before a meal or 2 hours after a meal to maximize bioavailability. We can increase this medication every 2 to 4 weeks based on the IGF-1 and clinical symptoms. And this is quite attractive because with the injectable somatostatin receptor analogs, we have to wait a couple of months before we can change the dose because it takes a longer time to normalize the IGF-1. Acro-TSQ is a quality of life questionnaire for patients with acromegaly. And this was a nice study which showed that the oral octreotide actually even had an effect in the quality of life. So this study showed that the injectable somatostatin receptor analogs had a 50% poor impact on daily life, and 75% of patients experienced gastrointestinal side effects, local site injection reactions because of the injectable somatostatin receptor analog. And with oral octreotide, there was definitely more patient satisfaction, more convenience, emotional well-being, and less breakthrough symptoms. The overall work productivity loss was lower, and the activity impairment improved as well. So going over other advances and other medications, lanreotide autogel is a new syringe. It was in the market since 2019. And Daphne Adelman, I'm not sure if she's on the call, but she was really the lead to get this particular device approved. So this was actually a conglomeration of 5 different independent studies, which was carried on by Ipsen. And they tried to find out what the best device would be, which would be patient-friendly, easy to use, safe, and so on. And what they did was they improvised on the older autogel lanreotide, and this is the newer device. And you can see here that there's a nice needle cap covering needle for patient safety. There's a tray, there's an easy flange so that the fingers can hold it for easy access and delivery. There is also a see-through or a transparent body, so you can actually see how much of the medication is left in the system. So this was really a wonderful initiative by Daphne, and it really highlights how important it is to make sure that these are user-friendly devices as well. And more good news for lanreotide. This is another interesting study which is ongoing, which talks about prolonged release formulation of lanreotide. So right now we are using it Q4 weeks. This is actually a phase 2 study looking at lanreotide every 12 weeks to deliver higher doses, and at least the preliminary results have been quite encouraging. This is another formulation of octreotide. It's currently in phase 3 studies, so CAM 2029 by Camaris. This is again an extremely interesting technology where this is it's a self-injectable pre-filled injection where there's a fluid drop of octreotide which is put in here, and then that forms a nice matrix, and over time it degrades to let off the octreotide every single month. So this can actually be given once a month. It has this special technology which is called the fluid crystal technology, which helps to really prolong the effects of octreotide. It is very attractive because it's easy, it's subcutaneous. So, the patient can give it to themselves, the partner can administer it as well. So this is definitely very exciting news. Paltusotine, so this is another oral medication, very much like oral octreotide, that is also being studied. The difference is that this is a non-peptide as opposed to oral octreotide. It has the same affinity for somatostatin receptor type 2, much higher affinity compared to other receptors at the somatostatin level. And this has a longer half-life of 42 to 50 hours. So instead of the twice daily dosing, you could potentially just use it once. The studies on this are still ongoing. Preliminary data, and of course these are small numbers, shows that the IGF-1 levels could indeed be normalized in 87% or so. And there is a phase 3 study that's ongoing. I'm going to quickly mention ATL1103, which is currently in phase 2. This is very similar to pegvisomant because it acts at the level of the growth hormone receptor antagonist, and it helps to block the production of the growth hormone receptor. These are all the other newer interventions, newer, different molecules that are in study now. Very exciting time, of course, and I hope we get more and more treatment options for acromegaly. So in conclusion, combination therapy really helps in the management of acromegaly. It's cost-effective, better side effect profile. We always want to consider a multidisciplinary approach to patients, and medical therapy really does not adequately alleviate the burden of disease. We really need new arsenal in our management options for acromegaly. And of course, we have novel formulations which help to customize treatment better. Thank you so much for your attention. Sorry if I went over by a few minutes. We have our next talk now by Dr. Golfinos and Dr. Konzioka. Thank you.
Thank you so much, Needy. Let me see if we can get this up here. I'm John Golfinos. I'm the chair of neurosurgery here at NYU. And let me just get this started here. Great. It is my great pleasure to do this presentation with Dr. Konzioka, and we'll split it up. So I'll go first and Doug will then follow with radiosurgery, which is sometimes in real life is how it actually happens as well, often in real life. Dr. Konzioka joined our department in 2012. It was the 10th year anniversary of his coming to NYU. And we brought him over from the University of Pittsburgh, where he started and made famous the gamma knife radiosurgery program, stereotactic radiosurgery program at the University of Pittsburgh in conjunction with Dave Lunsford, who was also on the faculty there. And it was a great get for us to have Dr. Konzioka, to convince him to come to NYU. And then, of course, I can always remember the date because he arrived the day after Superstorm Sandy. So it's the 10th anniversary of both Sandy's arrival in New York and Dr. Kanzioko's arrival in New York, the latter being far more beneficial for the citizens of New York. He's also the Great Family, he holds the title of the Great Family Professor of Neurosurgery, which reflects his accomplishments in neurosurgery and also the generosity of people who've wanted to support our department, specifically the Great Family here in New York. And he's also, as I mentioned, has started our NYU Center for Advanced Radiosurgery, and he's a director of that. He also became this year the editor of the journal Neurosurgery, which is the most important and influential journal in all of neurosurgery. So really great to have him with us today. So I'm going to start off and talk about surgical considerations in acromegaly. And basically what I'm going to do is walk you through a case essentially and put you in the surgeon's seat. So you can see what we go through before, during, and after the surgery. This is our place here. I also want to mention this year, we were named the #1 department of neurosurgery in the United States. As chair, I get to say things like that in the US News rankings. So what are the goals? You've heard it several times now. We want to aid in the rapid and complete normalization of growth hormone secretion. Surgical removal of the tumor is really the biggest bang for the buck. It's the fastest and most complete method of normalizing growth hormone secretion. If you can get all of that tumor out, then we're talking about a cure, both of the tumor and an endocrine cure for the patient, curing their acromegaly. The other goal, of course, of surgery is to preserve the normal pituitary gland that's outside the tumor. And then, as we mentioned, cure, which means the prevention of recurrence. We're looking at lifelong cure with surgery if possible. What are the predictors of surgery? How do you know if you have a good chance at curing a particular tumor? It really comes down to size. So as we heard from Dr. Young in the beginning, microadenomas, those tumors that are less than 10 millimeters, we have a 70% surgical cure rate with those tumors, which is, it shows you that once we can find the tumor and get around it, we have a really good chance of getting a surgical cure. Cavernous sinus invasion, as Dr. Agarwal mentioned and Dr. Young, historically that was a predictor. It turns out to be less and less important as time goes along. When I trained in neurosurgery many, many years ago, we were sort of told that the cavernous sinus, those areas on either side of the pituitary gland, was off limits, that if you got in there, bad things would happen. And that's no longer the case. We now plan our approaches into the cavernous sinus to get any parts of the tumor that may have extended out there. And then the preoperative, a random growth hormone level done preoperatively will also be predictive of your chance of curing the patient. And that really reflects how much of the tumor, how big the tumor is. So again, it goes down to size, and also whether or not the tumor has invaded the cavernous sinus. Remember, those are venous sinuses. They're sort of blood-filled areas filled with venous blood on its way back to the heart. And so that once the tumor gets into that area, it's essentially pouring growth hormone into the bloodstream, and you can see much higher random growth hormone levels. And then, as it turns out, younger patients do better, and the reasons behind that are not fully understood, but that's also part of it. So you heard from Dr. Young before, and I'm happy to say that neuroradiologists are in fact our confidants. They see everything that we do. We can't hide our secrets from them. We have no secrets from our neuroradiologists. And that also makes them our therapists, because when things go well, everybody celebrates. When things don't go well, when you don't get all of the tumor out, or God forbid there's a complication, they're there for us. And as you heard from Dr. Young, they're also our cheerleaders. So they're there to say, even before the surgery, you know, this looks like one of those I've seen you do a great job on this before. Go for it. So they're really there as to keep us going as well. What do I need to know from the MRI when I look at it? I want to know, is it a macroadenoma or a microadenoma for those reasons we just said? Am I going to go for cure here? Am I going to have a good chance of getting a cure? How high does it go towards the optic nerves? I want to know that because I want to know if I'm going to get close to those. And where's the normal gland? That's a critical question because, as we mentioned, we want to preserve the normal function. The normal gland usually gets pushed out of the way by the tumor, and it either gets pushed to the left or to the right, and sometimes straight up. And we want to know that. So going in, we want to know where are we going to find that normal gland, because it tells us A, we're saving it, we're keeping that normal gland intact, and B, if we got to the normal gland, it probably means we know that we're around at least one side of the tumor. And then we mentioned again, does it get into that cavernous sinus? And that's just so we're ready for it. It's not going to stop us, but we just want to be ready for it. And as I mentioned, how high does it go above the gland? So here's a typical case. A 57-year-old woman noticed a change in her ring size. She had a sleep apnea workup, as you see, 7 years before she came to us, but it still wasn't obvious what was going on with her. And then in retrospect, over the 15 years before we saw her, her shoe size had gone from a 7.5 to a 9 wide. 3 years before she came to us, now her rings were getting tighter. She resized her rings. And then finally somebody said, you know, maybe this is acromegaly, and she went for an endocrine workup. And at that point, her growth hormone was 10.6, her IGF-1 was 405, where the normal would be 300 for her. This is an image, a cadaver image. So this is the head done in a cross section from the side. So you can see the nose to the front over here. You can see the top of the head at the top of the screen, the back of the head over here. And I realize sometimes as surgeons, we look at these casually, but these cadaver specimens are how we studied in the old days before computers. Was the only way to study anatomy. It's a great gift from people who donated their bodies to, you know, to medical science. This is really what we use to learn. So that we're not doing the learning in the operating room. We've learned it all before we get there. You can see the hard palate here, the tongue here, and then this is the nasal passage. This from the side is that sphenoid sinus. That's an air-filled sinus, just like the frontal sinus here, where everyone feels headaches. Most people don't feel their sphenoid sinus, but sometimes it can cause pain because it has you know, the same lining that the frontal sinus has. And then you see the pituitary gland sitting right here. This is a retractor that was used in the old days of pituitary surgery. Now we don't use retractors at all, but it would be, and this is even larger than the endoscopes we use. The endoscope would be about half the diameter of this. So we pass the endoscope directly up through the nostril, and you can see that it's a direct shot to the sphenoid sinus. You have to take down that bone that's at the front. You take that down and open up the sphenoid sinus. There's two natural openings. This is one of them. You know, that's how it drains naturally, normally. And we just make that opening much larger so we can get into the sphenoid sinus and then go right to the pituitary gland. And when there's a tumor there, this area gets bigger and it comes down into the sphenoid sinus, makes it even easier for us. And it thins out what is already pretty thin bone that's separating the gland from the rest of the sphenoid sinus, so we can get right in there. And you can see when you look out sort of to the end of the sinus, you can see the carotid artery in here, this red thing. The arteries are stained red on this image. So you can see the carotid artery that comes down and into the cavernous sinus. And you can see that there's this thin layer of sort of like a little skin, a transparent skin or translucent, that separates the cavernous sinus from the sphenoid sinus. Because again, one is filled with blood, the cavernous sinus, whereas the sphenoid sinus is filled with air. So that helps us there. And that's what it looks like on the MRI. Then there's an actual MRI that looks just like that specimen. And you can see a small tumor here down at the bottom. This was a tumor that we mentioned in this woman. You can see it off here to the right side. It's the dark areas Dr. Young mentioned. We're looking right at the patient. So top of the head here, right side, right ear will be here, left ear will be here. The eyes will be somewhere out front here. That's the optic nerve on the right, the optic nerve on the left, and those circles are the carotid artery. And that's the normal gland, the bright thing, and the tumor doesn't light up. And you see it here, it's a little darker on this image where the spinal fluid is now turned white. And this is what it would look like in that same specimen from the front. So that's the gland right here in the middle. This is the sphenoid sinus. We've come up through the nose. This is how the nose communicates with your throat, correct? Right at the back of the nose there. That's the opening to the eustachian tube that joins to the ear. That's how you normalize the pressure in your ears. And then these are the carotid arteries out here in the cavernous sinus, the big red things. And so all the action is for us here. We said the cavernous sinus is a venous structure. It's filled with blood. That's what the blue is. The blue staining here is for blood, basically venous blood, whereas the arteries are red. So this is where the action is. And on either side are the arteries and the cavernous sinus. And this is what it looks like on a reconstruction now. So the technique, basically, so we can rehearse the operation beforehand. This is virtual reality. We're rotating the patient and we're going to fly right up to the tumor through the nostrils. So you see, again, the arteries will be in red. The tumor is made green here, so you can see it. And we made the face translucent and the skin translucent. And now, as we come around, you see the brain now. We're stepping through the brain, and then it's going to give us a direct shot up the nose. We're coming around again. So now we're looking front to back, and you're going to fly essentially right through the tumor. This is exactly what it looks like when you put an endoscope in. So, and there's the tumor. We're going to go through the tumor and out the other side, and then look back at where we came from. These are arteries, big arteries, and important ones on the back side of the tumor. And again, looking at the tumor from the front here now, you can see the carotid arteries on either side. Right here is up at the front. And that's basically the view we get as we go into the operating section like that. So it looks like this in real life. And some of this will be, it might be a little, you'll see some blood here. Some people have a genetic disposition to at the site of blood. It's actually carried in your genes. It's about 10%. That means every year, about 10% of the medical students, the first time in the operating room, they'll pass out when they see blood, and it's a response. It's sort of how active your vagus nerve is in response to the sight of blood. This again is that 3D image coming around. So, and now the optic nerves are in yellow. So you can see as we go through the nose, we're flying right at it. Optic nerves on either side. There's the tumor, and this is what it looks like in real life. We use small instruments, so a small drill that allows us to get in there and drill off some of the bone. That's a suction that you see there as well. Whoops, let's go up here. I'm going to move it along a little so we can see it. And sometimes we'll have cottons in here. These are essentially surgical grade cotton that we can use to soak up excess blood and things like that. It'll take a little bit for this video to catch up, but you can see now we're exposing the tumor that sits there. And this is sort of giving ourselves, just drilling off some of the bone that protects the cavernous sinus because we want to go out there. And this is the tumor now hanging down at us. We're in that sphenoid sinus, that air-filled sinus, and the tumor is hanging down at us, and we're looking right at it, and just keeping things nice and clean with the irrigation. And you see again the tumor right here. So the nose will be out, and we've gone up the nose with the endoscope. So you're looking at the view through the endoscope. And we have our instruments are passed through the nostrils as well. So one nostril has the endoscope going up, which is thin and has the suction in it, and the other nostril we use to use our instruments here. And now you can see us coming around the tumor, drilling a little bit more. Let's move this along. And now you see we open the covering. All of the brain is protected by a thin skin. So once we open that, we're now looking at the tumor itself, and that's what a pituitary tumor looks like. You can see you can use various instruments to get it. Some parts of it are thin. It's usually thin and gelatinous like that. So we're looking at the actual tumor and taking it out. I haven't seen the normal gland yet. I know it's going to be to one side or the other. We knew that from the beginning of from that MRI. We knew that the normal gland was going to be off here on the left. And so that's exactly what you see. And that's exactly how the resection, how taking it out proceeds. You can see we can lift up the remaining tumor and look all the way around that the home where the normal gland normally sits. It's been replaced by the tumor there. And we keep going like that. I'm going to move this along so we can see the end of it, and basically that's it. So that's how the tumor is taken out. And you can see, the last little bits of tumor that are left, and we can get around those and get all of it out of there. And then at the end, basically cleaned out all of that place where the tumor used to be. And we see the skin that protects the pituitary gland from the rest of the brain. You can see it pulsating down along with the, the regular pulse. And that's what it looks like at the end. All of that tumor taken out. And then we replace it with a little bit of fat that we take from the abdomen to seal things off. We don't want to get a spinal fluid leak after surgery. And then we use this sort of artificial skin there that we can put back in. And that's what it looks like afterwards. So the tumor gone there. So that's really what it is. Just to show you that it doesn't always go so perfectly. Here's the opposite of that, in case it's too difficult. A 26-year-old woman that we had to use every sort of surgical technique we had. And you would know that because her preoperative levels were so high. You see the normal gland over here on the right. This is the tumor out here. And you can see it's well into the cavernous sinus here. It's pushing on parts of the brain, the temporal lobe. And so we know that it's going to be very difficult to get all the way out here. And you can see her preoperative growth hormone was 149, where normal is less than 2. So we knew that this was going to be very difficult to cure with surgery alone. And you see the extent of this tumor. It's all of this. This is the first try. As we go through, we got the part that was easy. Through the nose, we came back going a different approach to come a little more out here, again through the nose, out this way, thinking if we can just get further over there, we can get more of this. But the tumor in the cavernous sinus was just held by all of those little strands that are in that blood-filled sinus, very tenacious, difficult to get. So eventually we had to come in from above again, the regular traditional neurosurgical way, and get all of this out, and finally ended up leaving just a piece of tumor in the cavernous sinus, and that will be treated with radiation and radiosurgery, which will bring us right to Dr. Konzilka next. So what's new? I think the endoscope used to be new. I mean, 10 years ago, now it's the standard of care, but believe it or not, there's still some surgeons that don't use an endoscope because they just weren't trained that way. All of the young surgeons do it. Almost everybody does. And then using these advanced ways to look at things, both in virtual reality and even augmented reality. So we can sort of put the MRI, sort of have it snap right to the patient. So we're seeing the MRI and the patient themselves together. The intraoperative MRI you heard about from Dr. Young, that's been a big deal for us in taking these tumors out. Sometimes we find hidden pieces of tumor that we didn't see. And Dr. Passion, one of my faculty you hear from later, wrote a paper on this showing that in about 15 to 20% of the time, it made a difference in the surgery. So we didn't end up having to take the patient back to surgery on a later date. And then these are ways to look at the tumor itself. This is also a study in process here at NYU. So when we take tissue out, we can instantly get a sort of frozen section or an instant pathology read. So we can know whether it's tumor or not, or whether it's normal gland. And then we're using fluorescence to make the tumor glow, so we know where things are left. This is just so you can see what the operating room looks like. We're very happy here at NYU. When we built the new hospital, they let me design the neurosurgery operating room. So we have 7 rooms all to ourselves. This is what the intraoperative MRI looks like and how we get patients in. Basically, the tabletop from the OR transfers in, and we can hook them right up to the MRI while they're still asleep. And I showed you that virtual reality. We found it very helpful for us. This is where we have it up in the operating room so we can see it. That's what we're looking at when we're not looking at the patient. And so in conclusion, the virtual reality has helped us a lot. We want all that data to agree. And, these are 21st century things, including the intraoperative MRI. And the exciting thing would be to see what comes next, which would probably be robots will be the next thing, but that's still a little bit away. This is one of my mentors, Patrick Kelly, who was my predecessor as chair here, and one of the people who taught me how to do this type of surgery. I'm very grateful to him. Now I'm going to hand it over to Dr. Kanzioka, who will talk now about radiosurgery and the treatment. Doug?
Thanks, John. Let me bring up my screen. There we go. Great. Well, that was a tour de force of surgical technology, and as we've learned this morning, this is a complex problem that requires, in some patients, really a multimodal approach, and which is sometimes lifelong. Obviously, cure is desirable for patients and families and physicians. But as you saw from some of the cases, including that last one with involvement of the cavernous sinus and compression of the temporal lobe, this can be a big challenge. And I'm really personally thankful for all the patients with acromegaly that I've had the privilege of getting to know over the years as they've tackled what are some of the most interesting elements of care that we see in neurosurgery. One of the things is that there's been a long history of the use of radiation for patients with persistent acromegaly, and have the opportunity to work in this field for almost 30 years. And I think a lot has been learned. Obviously, the use of radiation in medicine goes back many, many decades, but it wasn't very focused. And as Dr. Golfinos just showed you, the precision of surgery is extremely focused. And if we even get to robotics or certain types of imaging to make sure that last little bit of tumor is removed and not just hidden behind some blind corridor, the same thing works with the use of high energy radiation. In the old days, radiation was lower energy because it wasn't focused, because the normal pituitary gland was getting treated, the brain around the tumor was being treated. People would get late memory problems from treatment of the temporal lobe. These were all complex. But in the last 20 years, this has been a different situation where the ability to really target things utilizing very specific machines dedicated for this, together with high resolution imaging. As Dr. Golfinos mentioned, the radiologists are the evaluators of what we do, but they also help us guide what we do, and particularly when it comes to pituitary tumors, as I'll show you. And of course, our goal is tumor growth control, stopping the mass. We've seen large masses. Of course, endocrine remission of the hormone hypersecretion, trying to avoid long-term suppression therapy, which can have side effects in some patients, and keeping the pituitary gland functioning as best we can. And as I mentioned, going back to some—
Sorry, Dr. Kanzioka, are you sharing your screen? We don't see your slides.
I am sharing. Let me see here.
There we go.
Thank you.
Sorry, Doug. I thought you were just freelancing it.
Oh, no, sorry about that. Yeah. So one of the, as I mentioned, obviously complex, and I think one of the things that was mentioned, as I said a few minutes ago, that doing this in a more sophisticated way was just showed better outcomes than the old days of large field radiation. One of the things is that there's been a lot of publications lately, and mainly through multi-center registry-based studies, because of course it's not that common that patients might fail both medicine and surgery. So each center never has a huge volume of acromegaly patients. So together with pooling data, we've been able to learn things a lot better than just going alone from one group. And you can see in this study of 371 patients recently published, the time to durable remission was about 3 years, and that typically has been achieved in about 50 to 70% of patients on average, and those that have radiosurgery. And you can see the classic type of case is someone who's had prior resections, in this case 2, with tumor that's left as in the cavernous sinus or cavernous sinus wall. Not much tumor in the sella, but in this location, which has been more difficult for surgical resection without submitting the patient to increased risks of double vision or facial pain or trigeminal injury or vascular injury. And one of the things that's been important across all the studies is that smaller tumors allow higher radiation doses due to the fact that the most important structure nearby is the visual system, the optic nerve and chiasm. So that limits how much radiation can be used, and the higher the amount, one can get better hormone control. It's sort of easy to stop the mass from growing, and as I'll show you, that's usually achieved in probably 95% of patients, but it's the main issue is the hormonal control. Now, one of the things that was mentioned, is that if surgery is done, obviously the goal is to remove the entire tumor and hope for cure. But in some patients who may not be suitable for that, sometimes based upon age, they might undergo primary radiosurgery as opposed to that secondarily after a prior resection. And I think the news in a small cohort, again, multi-center, there's only 78 patients in this recent study, was that there were similar outcomes in doing radiosurgery primarily or secondarily. I think that's good news if those patients need it. The technique of this is, as I mentioned, has to do with precision radiation that involves placement of a stereotactic frame so the head does not move, and then the use of excellent imaging. And I'll show you examples of that, such as here. So we're looking at the tumor now in the coronal plane, same straight up the view that Dr. Golfino showed you with the endoscope. Now we're looking at tumor into the wall of the cavernous sinus. Here's the carotid artery in red on his cadaver image that he showed you earlier. Here's the gland on this side. And the nice thing in this case is that there's a good distance from the optic chiasm to the superior border of the tumor, and you can see the radiation plan here. So that the dose even at this structure in the lateral cavernous sinus is extremely low. The dose of the optic chiasm is extremely low. And as I mentioned, controlling the mass is usually achieved fairly well at this type of technique. And you see 2 years later, there's not much residual tumor present. And in a case like this, the IGF-1 level had decreased significantly from 865 down to 429 in this setting. So one of the things is that it takes time. I think one of probably the most troubling aspects of the use of radiation for any type of tumor that's a benign tumor is that the outcomes are delayed and slow. And if a patient is metabolically compromised, the concept of having to wait, which is 12, 18, 24, 36 months, as you see, and perhaps even longer on medical therapy, is just the nature of this. And it's, the ability to speed up the radiation effect is really related to dose, which is limited by the optic chiasm. So you can see that over time, this endocrine remission rate, goes up. And in this series that we had a number of years ago, one reaches about 60% eventually. But you can sort of stratify this out according to different patient groups. The IGF-1 index is less than 1.5, patients do better. And if the adenoma was a non-invasive type, and this is sort of a non-cavernous sinus type, they also did better. This relates, I think, mainly to the ability to see the tumor, because with a precision radiosurgery approach based on imaging after surgery, it can be difficult to interpret the images to know, yes, that's the target. because we can see that gray tumor as I showed you in an image a second ago, but there could be a little nest of tumor on the other side of the cella that we don't see that well. And we've seen it many times where we've got a great imaging response, but there can be persistent hormone hypersecretion, and later on another little spot sort of shows up, which was likely there before, but we just did not appreciate it. Fortunately, the morbidity profile of doing this is very low. In my own experience, I've never had a patient develop an optic nerve problem as it relates to the nerve chiasm from a vision perspective. I've only seen it in patients who have had prior radiotherapy years ago, but never in a fresh radiosurgery case. But you can see at the last line, the chance of a pituitary hormone axis deficiency is about 25%. And typically, as you can see, this is commonly related to hypothyroidism, hypoadrenalism, sometimes hypogonadism there. Identifying the pituitary gland. As you can see, here is a similar image to what I showed you before, where the gland is brighter with contrast. The tumor picks up contrast more than the brain, but less than the gland. And this is a dynamic image, which can be post-processed. And this is our radiologist looking at how fast the contrast goes through tissue and to what degree. And you can see that there's a difference over time in terms of what the degree of enhancement in the gland versus the tumor, and this sort of color codes for this. And we do this a lot. It's frequent that we'll either do this before the case or with our radiologist that morning to help try to find every little piece of tumor that we can see. Having said that, we're not just looking at treating the tumor or ignoring the optic chiasm. I think the next step is to try to even reduce the dose to the pituitary gland and pituitary stalk, and that may have an impact at keeping that 25% chance of hyposecretion even lower. And you can see that this hypopituitarism concept is very consistent in the literature. And you can see it at 4 years, again, about 25% of patients in this study, the commonest being thyroid hormone. This is for both non-functional tumors, Cushing's, and acromegaly. One of the questions is, do I need to stop hormonal suppressant therapy before radiosurgery? This has sort of become standard of practice. The concept is that radiation is damaging the genetic material in the tumor cell, which is sort of suppressed by the drugs. We want the DNA to open itself up to radiation strand breaks. And so being off suppressant therapy, we think is a benefit and has been shown in some limited studies. How long? We typically recommend 4 weeks, maybe 6 weeks is even better. And usually this can be restarted a week or two afterwards. So this is our protocol to do this, if possible, 4 to 6 weeks before and 1 to 2 weeks afterwards. One of the things that young people sometimes ask, and physicians care about, of course, is the fact that the history of radiotherapy for pituitary tumors was associated with secondary tumors, and the chance of another tumor showing up, usually a benign tumor like a meningioma, was in 1 to 2% with large field radiation to the cellar floor area. With radiosurgery, it's extremely rare, mostly because the radiation is very, very precisely delivered to smaller volumes. So we have found that the risk of a radiation-associated malignancy, and this was a study of 5,000 patients, it's the largest one ever done, was no different than the general population risk of getting a cancer. There's a risk of secondary neoplasms, which could be elevated in children with a prior cancer, but not in adults. So again, the risk is very low. So to summarize, for clinically persistent acromegaly that's after failed microsurgery based upon tumor location, this can be safe and effective, and we can get to about half of the patients no longer requiring long-term medical suppression. Thank you.
That's terrific, Doug. Thanks so much. So we will hold questions, I think, until the break, and we're going to have a panel discussion with all the surgeons on there and people and the presenters from this section.
Thank you. Thank you so much, Dr. Golfinos and Dr. Konzioka. I am very happy to introduce the next speaker, Dr. Ewan. So Dr. Kevin Ewan is a professor of medicine at the University of Arizona College of Medicine. He's also the medical director of the Barrow Pituitary Center and the Barrow Neuroendocrinology Clinic at the Barrow Neurological Institute in Phoenix, Arizona. The focus of his clinical practice is on the diagnosis and treatment of pituitary and adrenal disorders. Dr. Yuan earned his bachelor's degree in medicine and surgery at the University of Sheffield in the United Kingdom, and he trained in internal medicine at the University of Southampton and completed his research fellowship at the University of Cambridge. He's the current editor-in-chief of the Growth Hormone and IGF Research Journal, and he's also on the editorial boards of several other endocrinology journals. We keep inviting Kevin because he's wonderful. He's a great speaker, but thank you so much, Dr. Yuan, for being here. Dr. Yuan, you're on mute.
Okay.
Yes, we
About
can
that.
hear you.
Okay.
Yes.
Okay. Thank you, Nidhi, for inviting me, and good morning, everyone. And as you can see, I'm in Arizona. And I was asked to give a talk on COVID, which obviously, as everyone knows, is a very hot topic. And also, as I was preparing for this talk, is also rather challenging because things keep changing, and it's certainly something that we are still learning a lot about every day. And looking through the literature, you'll see I found that there isn't really much published on COVID-19, at least where its impact it has on patients with acromegaly. But so some of the data that I'm going to present to you would be relevant or is been presented previously in patients with pituitary disorders, which obviously can overlap with patients with acromegaly. And this is my disclosures. So, so as you know, COVID-19 obviously is derived from a coronavirus that initially was described in December 2019 and was rapidly spread as a result of the virus and declared a pandemic in March 2020. And because of its crown-like spikes, that's how it's named coronavirus. And you can see that below here is a list of 7 coronaviruses, of which this is COVID-19 is one of the 7 coronaviruses that can actually infect people. So quickly going through, you can see that the infected person, or how does one get infected with this virus? The infected person expels the virus-laden droplets, which is picked up or inhaled by the other person through the nasal passages, which then goes into the lining of the nose and throat. And then importantly, I think one has to understand that the attachment of the virus onto the receptor, the ACE2 receptor, is crucial because this is where the corridor or where the pathway of which the virus then is able to enter the cell and hijacks the cell's machinery, changes the overall DNA and the structure, and like a photocopying machine, makes many copies of itself, and that's how the virus replicates in the body. And you can see here, oops, sorry. You can see here, this is a cartoon of how the virus binds to the ACE2 receptor. And initially what you see here is that the virus on the left-hand side here, together with the S1 and S2 component, attaches itself to the ACE2 receptor and requires the TEMPRESS protein to exert its effects in cleaving the attachment between S2 and S1. And the cleavage here actually allows the activation of the S2 domain, which contains the contents of the virus to be fused and to be expelled into the cell, and therefore exerts its effects further down the line. So the symptoms, as many of you may aware, and also perhaps will know from people who have been infected, or also perhaps some of us also who have been infected, is that it can range from very mild to no symptoms at all to severe illnesses, and can be present between the time frame of 2 to 14 days after exposure. And it is, and the symptoms that are underlined are certainly the ones that are commonly described, but by no means you will note that there are also many other accompanying symptoms that may also resemble a viral infection, because this is obviously this is a virus, such as fatigue, muscle or body aches, headaches. And obviously the key symptom that is frequently described, or some that is described that is associated with this infection, is the loss of taste or smell. So clearly many patients, we know that the emergency warning signs that promote or trigger the importance of seeking medical attention clearly is the increasing or the worsening of breathing, the pain on the chest simply because of the persistent cough, and the reduction in oxygen levels that promote confusion and disorientation. Those are the telltale signs of emergency warning signs that require emergent medical care. And as you know, also, it's not surprising that patients who are susceptible, certainly the elderly or those with underlying illnesses such as obesity, high blood pressure, heart disease, cancer treatments, patients on cancer treatments such as chemotherapy, and poorly controlled diabetes are certainly risk factors. And if you look at that list at the bottom here, you will see that patients who have acromegaly can have some of those comorbidities, certainly like high blood pressure, heart disease, and certainly diabetes, which are certainly more susceptible to occur in patients with acromegaly. This is the list that actually is put out by the CDC. And again, you see that, again, no surprises there, that these are the common or the risk factors of patients who are susceptible to develop COVID-19. And the ones that I've just highlighted here are certainly some of the ones that can overlap with patients with acromegaly. So why are the endocrine organs affected by COVID, or can be affected by COVID-19? I think it's also related to the fact that many of these organs have the ACE2 receptors on board. And this cartoon here essentially summarizes the effects of the viral infection on each individual endocrine gland, ranging from, certainly in my field where I'm when I'm sort of mainly looking at patients with pituitary disorders, you can see that certainly there's the dysfunction of the hypothalamic pituitary dysfunction, to changes in sodium levels because of the effects it has on hydration, and also on patients who may develop diabetes and diabetes insipidus as well. It can also affect the testicles, affecting the fertility in some patients, the bones, particularly the lowering of vitamin D levels, and also the effects in reducing the secretory effects of the beta cells in producing insulin. So diabetes can occur, or actually can worsen, in those already who have diabetes. Patients who have obesity certainly have many other comorbidities. The adrenal gland, again, very important not to miss, especially it can affect the function in reducing cortisol secretion, and therefore raising the risks of adrenal crisis. And also, just like any other infection that can occur, it can also have an impact in causing inflammation in the thyroid. And so this sick euthyroid syndrome is certainly not surprising when it's associated with any viral illnesses. So again, you can see that patients with acromegaly can have a number of these associated comorbidities, particularly heart disease, diabetes, sleep issues, and certainly changes in the skeletal structure, which can affect and derange or deform the chest wall, which obviously can lead to mechanical breathing problems as well. increase in soft tissue swelling, which can occur and may predispose to sleep apnea, and also the intrathoracic collapse. And so the other thing that also that has been postulated in the literature as well is that patients who have hypertension or high blood pressure may be treated with ACE inhibitors, which are medications to treat blood pressure. And that is also used quite commonly in patients with diabetes as well. And this could also facilitate the COVID-19 development because of the increased ACE2 receptor expression. So how are patients with acromegaly more susceptible? Again, given the changes in the chest wall deformities, upper airway factors, these are the factors can actually affect and reduce oxygen delivery to the lungs. Kyphoscoliosis is the change in your posture and in your spine. You have soft tissue swelling, and you also have potentially an enlarged heart and heart failure. Some of the hormone deficiencies, again, that I have shown you earlier from the previous slide in the cartoon, where other hormones can be affected because of the effect of the virus on the endocrine glands. So adrenal insufficiency, which again increases the risk of adrenal crisis if the infection is especially severe, and growth hormone deficiency as well, especially in some acromegaly patients who may develop growth hormone deficiency following several surgeries and also radiation therapy as well. And the idea is that growth hormone itself is an important hormone that could help support and facilitate the immune system. And so this is something that has been suggested, that patients who have changes in growth hormone levels, certainly the patients who are deficient may be more susceptible, at least in terms of their ability of the immune system to fight the infection. So, how do you actually approach a patient who has the possibility or is concerned of having COVID, and also on top of that acromegaly? So, if no visual compromise is noted, and during the height of the pandemic, at least in my institution, I've had to pre-treat patients with medications initially, at least while we were waiting for patients to be able to be scheduled for surgeries, because at that point, a year or so ago, surgeries were still being delayed or deferred because of the situation that we had in our state. Obviously, follow up with telemedicine visits. However, if there is a mass effect, certainly the tumor, if the tumor is large enough to affect and compromise the vision, or if the headaches are getting worse, then the surgery can be expedited, and patients need to be explained about that situation as well. So what are the aims of initial medical therapy for patients with acromegaly during the pandemic? Certainly, we have to address the associated comorbidities. These are certainly very important factors that can affect the quality of life of patients, particularly rheumatological changes, also heart disorders, and also the impact it has on exercise capacity and endurance. As for the sleep and the breathing issues, again, especially if patients are already on CPAP, to continue with a CPAP to stabilize the lung function. But again, one has to be very mindful of the symptoms, and obviously if the symptoms do deteriorate or worsen, then clearly they need to be admitted. So it's not something that can be taken lightly, and certainly if their symptomatology, their breathing issues are worsened, they need to be referred to be seen and to be assessed, and perhaps maybe even hospitalized. Patients with acromegaly who have had surgery certainly can also develop other pituitary hormone deficiencies, and I'm going to list down each individual hormone that could be affected, certainly from surgery and plus or minus radiation. And patients who have adrenal insufficiency may be also at risk of infections, and clearly they may be more susceptible to being infected with COVID as well. And certainly treatment with the treatment with a steroid replacement is important to avoid the adrenal crisis and to appropriately treat them and increase the dose, stress dosing these patients, especially during the time when they are ill. And we tend to counsel our patients about using the medic alert brace and also to call the office in case they are unsure of what to do with their steroid dosing, especially when they're ill. And my nurse does spend some time counseling them about what to do with the sick day rules and to ensure prompt stress dosing is adhered to during this time. If they have a fever and the fever is persistent with symptoms, then we advocate increasing the dose to 20 milligrams every 6 hours, and those who are on prednisone 10 milligrams every 12 hours. And importantly is to avoid getting dehydrated, because with the fever, dehydration can be a problem. And so we tend to encourage patients to drink regularly and to monitor their urine output. But again, be mindful not to delay seeking medical advice if they're unsure or if their fever is not subsiding. Continued clinical deterioration is important to be recognized, and especially if they are not able to take anything orally, injections of hydrocortisone, and this is where patients need to be equipped to have these injectables at home, injectable hydrocortisone at home, just in case something like that happens and they're not able to seek medical attention. Or especially if they are not able to get to a hospital on time and if they are having persistent vomiting and diarrhea. So, so again, adequate hydrocortisone or adequate steroid coverage is crucial. By no means should be given either by injections, especially if they're not able to keep anything down. What about diabetes insipidus? Again, fortunately, not that common in our patients with acromegaly, but certainly is something that needs to be kept in mind, especially given the fact that patients, regardless of whether they have acromegaly or not, but if they have diabetes insipidus, they're always at risk of dehydration. And if you couple that with the fact that they have underlying fever, diarrhea, and vomiting, the risk of dehydration increases substantially. And so they may need to underdose their desmopressin slightly if access to testing is limited. And this is because you want to make sure that the sodium levels are also maintained and they don't overdo it. So it's okay to urine slightly more, but patients often can compensate that by drinking a bit more to avoid changes in their sodium levels. But most importantly, patients need to have enough of their medications at home, because if they are not able to go out and get medications or get their refills. What about the thyroid, the gonadal, and the growth hormone replacement? So again, thyroid, no dose changes are needed during the time if the infection occurs. Testosterone in men and estrogen in women, again, no dose changes are needed. For patients with acromegaly who, again, rarely, if they do over time develop growth hormone deficiency, again, this is uncommon but can happen. Again, growth hormone dose changes are not needed, but if growth hormone deficiency is suspected, then further testing is needed, although it doesn't have to be performed immediately. Testing for growth hormone often can be done in the cold light of day when patient is stable. Just a quick word about long COVID, which is certainly a new phenomenon that we are learning. Has been reported to occur in roughly between 5 to up to 50% of patients. So it's not something trivial. This is a syndrome where new returning or ongoing health problems occur after being infected with COVID-19 for beyond the 4-week mark. Again, patients who are certainly susceptible are those who had initial COVID-19 that had a severe infection, and also those who are not vaccinated. Again, this is a clinical diagnosis. There's certainly no diagnostic tests that are available to help make this diagnosis. So it can sometimes be a little challenging, especially when patients can have very vague symptoms of fatigue and ongoing fatigue and breathlessness, which may be attributed to long COVID or could be related to the fact that patients are still recovering from the infection. This is one of the few studies that has been published looking at the effects of long COVID on symptomatology. You can see here fatigue and the effects it has on smell and taste is certainly the two most commonly reported symptoms, followed by hair loss, headaches, breathlessness, and insomnia. Again, so these symptoms, as you look down the list here on the left-hand side, you'll see here that they are pretty non-specific and can in fact occur with any viral infection. And certainly patients who have been found to have or reported to be depressed certainly have a higher cortisol level, whereas those who continuously report of general fatigue tend to have lower growth hormone levels and higher T4 levels. Those who have a issue with the taste and smell certainly have low cortisol levels. And the general fatigue symptoms tend to be slightly more common in, certainly males are certainly more commonly affected, and those who are older. Whereas the effect it has on taste and dysgeusia, again, patients who are positive are certainly those who are older as well. And there's also a gender predisposition. Certainly, females tend to be more affected in terms of hair loss. So these are the reported symptoms that have been published on this on long COVID. Now, what are the symptoms of long COVID that can overlap with acromegaly? And you can see here all these symptoms on the left, not only acromegaly, but other pituitary disorders as well. And you can see here that pretty much every symptom that is reported with long COVID, patients with acromegaly can also report of. So there's a huge overlap as to which is caused by long COVID and also or COVID itself, and which is related to the underlying disease of acromegaly. What about vaccinations? Again, obviously, as you know, that it's encouraged in the medical community, and some patients, most patients actually don't report of any symptoms, although you'll hear that some do. And so certainly we advise patients to adhere to commonsensical measures such as plan lots of rest and well hydration. Look out for the injection sites in case there's any local effects. And clearly this is a vaccine, so some patients can report of headaches, general joint aches and pains, sometimes mild fever as well. And some patients can also report of an allergic reaction, just like any medication. Allergic reactions can be a problem. But for most patients, really there's not much in the way of symptoms. And so the common thinking is not to advocate extra steroids unless fever develops or muscle and joint pains become severe or become more prominent. A quick word on Paxlovid, which is currently not approved yet, but is authorized for emergency use by the FDA, and it's limited, or it's advocated for use in patients with mild to moderate COVID, both in adults and pediatric patients above 12 years of age. And these are patients whom are deemed to have high risk for progression to severe COVID. And the idea is to reduce that severity after being infected. And there are two components to this medication. You have the nirmatrelvir, which inhibits the COVID from entering the uninfected cells, and ritonavir, which shuts down the metabolism of nirmatrelvir in the liver. And so it is used and is advocated, or it is recommended to be used within the first 5 days of being infected. It comes in 3 pills that you take twice daily for 5 days. It comes in a blister pack. It does have some drug interactions and some contraindications to other drugs, but it has been shown in almost 90% of patients to less likely to develop severe illness and death. It is not being used yet or being studied yet in patients with long COVID, and certainly in the last few days we've been notified that certainly studies are now being thought about and being planned of considering using Paxlovid in patients with long COVID. So just a slide to address the general treatment strategies of acromegaly patients who have underlying comorbidities during the COVID-19 pandemic. So again, these are simply general statements, but again, important to be aware of, which again, I think many of you would know, and it's certainly not a surprise to optimize the treatment of blood pressure, heart disease, optimize weight management, blood sugar control, and also try and limit steroid doses, and employ caution on the necessity and dosing and frequency of local steroid injections, particularly in patients with acromegaly who may need steroid injections for their joint pains. So take-home messages, the pandemic has certainly impacted the way we see, provide care, and also our provider and patient attitudes, and to a certain extent at the height of the pandemic has limited access to testing and treatment. And so despite COVID-19, patients should also seek medical attention to minimize delays in diagnosis and management. Pay important attention to breathing symptoms, duration of fever, and avoid the adrenal crisis if possible for those with adrenal insufficiency. And certainly the comorbidities associated with acromegaly does place patients at somewhat higher risk of more severe COVID infection and may be considered for Paxlovid. Persistent symptoms of acromegaly and changes it has on, certainly from the treatment of acromegaly on other hormones, may be a factor in causing the persistence of general fatigue that may be confused to be part of the long COVID symptoms. Adhere to daily medications and adapt to increased replacement doses, and close follow-up of underlying comorbidities is important. With that, I thank you for your attention and happy to answer any questions.
Thank you, Dr. Yuan. Very important topic, of course, acromegaly and COVID. And we have a few questions in the chat. Dr. Golfinos is going to kindly moderate the session. We'll have to cut down the questions just in the interest of time, but we can start now. Thank you.
Great. So I just want to introduce our other panel members. We do, in fact, as you've heard, have an embarrassment of neurosurgical riches here at NYU. And that includes among them Dr. Donato Passione, who's one of our assistant professors in neurosurgery. He's actually our director of quality assurance and does an amazing job in showing better ways for us to do things, actually, really incredible. And then Dimitris Plekantonakis is associate professor of neurosurgery in our department. Dr. Plekantonakis is a surgeon scientist. He's an NIH-funded scientist, so one of the people who really is working on exactly what makes these tumors tick, has a profound knowledge of this area. And then finally, Dr. Chandra Sen is our Bergman Family Professor of Skull-Based Surgery, again, holds another endowed chair in our department, reflecting his time in neurosurgery and his incredible contributions to skull-based surgery and to pituitary tumors in particular. He's also a world authority on chordoma, another tumor that occurs at the skull base. So we have the right people to ask, so I'm going to throw out the first question. Somebody asked, we recently found out that our 23-year-old daughter was diagnosed with acromegaly. We've been told it was found very early and the tumor is only 1.4 millimeters. She started octreotide 3 weeks ago. We've been told that her tumor is too small to be operated on. Is this an accurate assessment? A 1.4 millimeter tumor. So Chandra, do you want to talk about that?
If it is truly seen in a good high quality scan, as you saw from the previous talks, and the biochemical profile just confirms that you have acromegaly, then it should be operated upon because it's potentially curable.
That's great. Dimitris, how would you find a tumor like that? What would you do preparation preoperatively?
Imaging, high quality imaging is the best way to identify such tumors. And as Dr. Young said, we have the appropriate hardware and software here to detect even very, very small tumors. So good imaging, and as Dr. Sun said, a tumor like this, even if it's really small, should be operated on because there's a very good chance of a cure.
Great. And how do you, when you're in the operating room, how do you know you've gotten the tumor when it's that small, when it's that tiny?
Yeah, I mean, I think this is a perfect example of use of intraoperative MRI. I mean, when we're trying to find something this small, it is a little bit of a needle in a haystack of a normal gland, and you don't want to disrupt that normal gland too much to cause any long-term endocrinopathy from normal pituitary function. So this is one where the intraop MRI should show you that you've gotten this out and that you've gotten the right lesion. Dr. Young showed one of those cases where, you know, we saw something that looked like it could be the microadenoma, but then even on the intraop MRI, we were able to see that there was another area that was actually more concerning. So back to, you know, Demetrius's point about the high quality imaging, I think is going to be determining of what you're going to do, but then also intraoperative imaging to confirm that you've gotten it out. Because as you said, this could be a cure.
And then let me ask all three of you. I don't see other questions, so we'll ask the audience if they have any, please send them in. Otherwise, I'll send this question out to the three of you. Recently, it's sort of become more apparent to surgeons that the tumor can be attached to the dura, to the covering of that gland, either at the wall of the cavernous sinus or even on the floor. Have you started to resect dura when you're taking it to cut the dura out, when you're taking out these small tumors? Any one of you can dive in on that.
I think in a secreting tumor or a functioning tumor, I think all involved tissue should be removed. And even with that, you don't get, if you have like the cavernous sinus involvement, or even if you take that, it gives you an increased chance of a cure, but it does not come close to 100%. So invaded tissues have to be removed, but that sort of is getting towards the boundaries of a cure.
Yeah, I agree. I think I try to resect as much involved tissue as possible, the dura whenever possible. I also use coagulation if a resection is not easy surgically, a resection of the dura. But the more you can take, the better with those tumors, for sure.
Yeah, I agree. I've gone to routinely taking the wall, the cavernous sinus for anything that's laterally based. So even if it's coming up to the wall, but doesn't look like it's grossly invaded, I'll take the wall with it, because we find that more and more often as we look at that tissue, it does have involvement of cells. So I think you have to be aggressive here.
So you're sending that to the pathologist separately to have them look at that specimen and see if there's
correct. Yeah.
Right. Edie, I think we're about 10 minutes over, so I don't know if you want to.
Thank you. Yes, I have one question, because I think we did push that back to after Dr. Ewan's talk. So Dr. Ewan, there was a question on one of the previous chats which asked about the impact of acromegaly, the impact of COVID, and to see if COVID could actually be a causative factor in acromegaly, and if you had any thoughts about that.
Yeah, no, that's a good question. Again, hardly there's any literature reporting on that, but I think most of the time when you look at the pathophysiology of COVID, which affects the immune system, I think most likely some of these endocrine dysfunction is probably related to the hyperactivation of the immune system, a bit like the hypophysitis picture that comes along. So perhaps maybe more likely the deficiencies in hormones or deficiencies in the pituitary hormones are more likely to occur rather than increased production of hormones. So I've not heard of acromegaly developing post-COVID, but certainly deficiencies or hypopituitarism or hypoadrenalism developing. So, but again, you know, COVID is such a crazy illness, you know, you never know. But so far, not so much. I don't think that's certainly a big issue of COVID causing acromegaly.
Great, thank you. And thank you so much to all our panelists. We are going to move on to the next section now. And I see some more questions on the chat, but we'll have to wait for the next break, which is going to be at noon. Thank you again. All right, so to introduce our next speaker, which is Jill Cisco. It's an absolute pleasure. Jill Cisco is the president of the Acromegaly community, which is a patient organization which helps educate patients and loved ones regarding this rare disease. She provides very good guidance on how to cope with their difficult illness. Since Jill's diagnosis in 2005, she really has been an influential advocate towards a better quality of life for acromegaly patients worldwide. In 2008, Jill became a leader in patient advocacy, and she sat on several acromegaly advisory boards and committees. She has presented the patient perspective of acromegaly to the FDA and co-authored several medical journal articles and abstracts regarding acromegaly. I had the pleasure of first meeting Jill just 2 nights ago, actually, on a dinner forum, and it was an absolute pleasure. I can tell you everything you hear about Jill is accurate. She really is a force of nature, very inspirational, and she's been fighting for patients with acromegaly, raising awareness for all these years. So thank you, Jill.
Hi, welcome to Acromegaly Quality of Life, Challenges in Everyday Living. I am Jill Cisco. I'm the president of Acromegaly Community. I thank you for attending today and helping to empower yourself to learn the knowledge that it takes to help take control of this condition and to live your best life. So with that being said, understanding acromegaly. Acromegaly is a rare disorder characterized by excessive circulating levels of growth hormone and insulin-like growth factor 1. Roughly 25,000 people living with acromegaly in the United States. There are 3,000 new cases diagnosed every year, and the median age of diagnosis is age 40. Untreated acromegaly is associated with physical changes and systemic complications, such as headache is one of the leading complaints that leads to an acromegaly diagnosis. Physical changes, which include brow prominence, nose and lip enlargement, soft tissue hypertrophy, and acral overgrowth. Hypertension is reported in up to 50% of patients with acromegaly. And GI complications, including colon polyps, which is why it's so important to get those routine exams that it's even more important for us to because of the GI complications. Cancer, there is a slight elevated overall cancer incidence rate within acromegaly patients. It's not like a double-digit number, but there is a slight increase. Sleep apnea is reported in 60 to 80% of all patients with an acromegaly at diagnosis. And endocrine and metabolic disorders, and also things like bone disorders, which also include carpal tunnel and arthritis. The goals of treatment are biochemical control, tumor control, and symptom relief. The approaches to treatment include surgery, medical therapy, and radiotherapy. The first line of treatment is typically transsphenoidal surgery. It is the primary therapy in most patients. However, there are limitations. Sometimes they can't get all of the tumor, or due to the size, sometimes they have to do a craniotomy. But in roughly 50% of patients with acromegaly who undergo surgery, they require additional treatment. There are first-generation somatostatin analogs that are first-line medical treatment in the majority of patients with acromegaly. There is a second-generation somatostatin analog is considered if disease control is not achieved. There are additional treatments, which include dopamine agonist and growth hormone receptor antagonist, pegvisomant. Radiotherapy can also be used to control tumor volume or as a third-line treatment after unsuccessful surgery and in cases when medical therapy is unavailable, unsuccessful, or not tolerated. Despite advancements in treatment, disease still has a high burden for patients. I did a small timeline of some of the medical advancements. In 1567, the first clinical case was reported. In 1886, the term acromegaly was coined. In 1892, acromegaly is associated with a secreting pituitary tumor. In 1908 was the first surgical approach. In 1936, dopamine agonist was first used for the treatment of acromegaly. In 1973, the discovery of the somatostatin receptor. In 1988, regulatory approved the first somatostatin analog, which is octreotide injection. In 2003, regulatory approved the injection of pegvisomant. In 2007, regulatory approved the injection of lanreotide. In 2014, regulatory approved a third somatostatin analog, pasriotide, and it hits 2 more receptors than what the octreotide base, the first and the second. It is the third. And then in 2020 came the first oral somatostatin analog. Personal impact. So we live in a very visual world. The change in appearance has high social impacts for a lot of patients. GH, growth hormone, makes people more aggressive. So those hormonal changes also have an impact on patients. The physical, the joint pains, the soft tissue swelling, the headaches, the day-to-day symptoms of acromegaly have a huge physical impact on patients with acromegaly. Financial, the loss of work, treatment is expensive. Life, 62% of patients report that their symptoms interfere with their daily life. That's according to the Strasburger study. But I want to mention that we did a quality of life study, which we had over 350 participants within our group. And within that, more than 88% of our community members report that their symptoms interfered with their daily life. So that is even substantially higher than what the Strasburger study said. Because of this, I decided that more needed to be done in understanding this condition. And so I actually approached the FDA and asked the FDA if we could host a patient-focused drug development program. And this program took place January 21st, 2021. Within it, we brought in all the stakeholders within acromegaly, the physicians, the patients, the pharmaceutical companies, and the FDA to really learn the overall experience of the patient and try to determine what the unmet needs are within acromegaly. We asked the patients a series of questions. We had instant polling, and here are their answers. So one of the first questions, what medications or medical treatments have you recently used? As you can see, most of the patients have had surgery. They're using somatostatin analogs or growth hormone receptor antagonist or the dopamine agonist. One of the things that was shocking to me was that 37% of the patients showed that they were using antidepressant or anti-anxiety medication. I also think that that goes towards some of the issues that we're facing regarding the mental health part that isn't focused on a lot within acromegaly that I think really needs a larger focus. A lot of patients that live with acromegaly deal with anxiety or depression on an everyday basis. There are a small number of patients that had radiotherapy, and it even broke it down to the types. We also asked patients, what are the top 3 most troublesome acromegaly-related health concerns that you have? Joint problems, arthritis was the top complaint, fatigue, muscle weakness, anxiety, depression, just like how I was mentioning before, and then also headaches. I know that this said the top 3, but I don't want to discount any of the other issues because I know that they are issues that truly do affect the quality of life of patients. So we asked the patients, what specific activities of daily life are most important to you that you are not able to do due to acromegaly? And the number one thing that they answered was social interaction and participation. I once again think that goes back to the mental health challenges of living with this condition. And then exercise, participation in sports and recreational activities. But if you'll notice, right below that is household activities and attending school or having a job. So you can see that this truly does carry a huge burden for patients, even those that are treated. So we went back and we asked, in looking at the data, what were the most poignant revelations from our PFDD meeting? And this is what I believe is the number one thing brought out of this meeting. We ask patients, do you consider yourself biochemically controlled? Is your IGF-1 within the normal acceptable range for your gender and age? And if you'll notice, 22% said always, 35% said most of the time, 19% said sometimes, rarely, 6%, and never 11%. So roughly 17% of the people were rarely to never not biochemically controlled. But as far as, always to sometimes, that is a good substantial number. But then we ask, do you consider yourself symptomatically controlled? And those numbers dropped drastically. Only 2% said that they were always controlled. Most of the time, 29%, sometimes 18%, but where those numbers really increase, rarely 26%, and never 22%. That right there is 48% of our patients. Almost half of our patients consider themselves rarely to never symptomatically controlled. So I really think that more needs to be done in regards to why, if patients are biochemically controlled, aren't they symptomatically controlled? So understanding the burden of disease. This disease has a mental impact, a physical impact, and a financial impact. This disease hits us from all angles. We must also keep in mind that it affects the entire family unit. Be cognizant that high growth hormone can make us quick to anger. Do what you can to fight this condition by being compliant with medications and diet. And join the patient financial support systems for our medications. And if on Medicare, join programs such as Patient Access Network or HealthWell to help with the financial impacts of these medications in living with this disease. A perfect world, of course, we would have a better quality of life, but there are some other asks that we have. It is a deeper understanding of this disease and how it works. We still have so much to learn regarding this. Better symptom control. Many patients experience symptoms even though their levels are within range. Patient support, universal access and reimbursement for medications in acromegaly. Everyone, physicians, pharmaceutical companies, and patients working together for a better quality of life and a cure for people with acromegaly. And awareness, diagnosis and treatment sooner for people with acromegaly. Diagnosis is the first step in getting better. This isn't just awareness for physicians, but also the general public too. We must do our part to help spread awareness. Awareness Day is November 1st. So go out and spread the word that acromegaly exists and it's hard to diagnose. So myself and the radio personality, Froggy, and son of a patient, Anish, all got together and we helped create an awareness video. And you need to know, if we don't help spread awareness, who will? And we hope that you will share this video on Awareness Day. Reach out to me. I'm happy to send you the YouTube link. And so I'd like to present this video. Thank you.
Acromegaly is an under-recognized disease with an estimated 3 to 4 people in every 1 million having been diagnosed in their lifetime. Often diagnosed in adults 30 to 50 plus, acromegaly before puberty is called gigantism. Acromegaly symptoms are common, including weight gain, fatigue, headaches, vision impairment, voice deepening, joint issues, enlargement of the hands, face, and feet, taking up to 10 years for symptoms to fully manifest. Due to its rarity and its subtle nature, acromegaly is difficult to diagnose and can lead to serious, sometimes even life-threatening health problems such as type 2 diabetes and heart disease. These problems are caused by the liver excreting an overabundance of IGF-1, a critical hormone that regulates the effects of growth hormone. Together, they regulate the growth of bone and tissue, and in high concentrations, change the way the body is able to handle blood sugar and cholesterol levels. These changes lead to an increased chance of heart disease, heart attacks, type 2 diabetes, etc. Acromagaly's most prevalent change is the unnatural growth of facial features shown by whitening teeth, nose, and fuller lips with soft tissue swelling. Other symptoms are excessive sweating, oily and thickening of skin. However, even though these individual symptoms by themselves are common among other various diseases, given time, these symptoms collectively resemble that of acromegaly. Even though acromegaly is considered a rare disease and typically diagnosed by an endocrinologist, there are tests and treatments in place to confirm and treat acromegaly. The main problem lies in the detection of the disease. When symptoms are present, request an IGF-1 test, or if still in question, the gold standard test is the growth hormone suppression test. This test seeks to examine one of the most important indicators for acromegaly, the increase in growth hormone levels. Single growth hormone measurements are not diagnostic of acromegaly, as growth hormone changes constantly and clears away rapidly. This produces various peaks and valleys of growth hormone, which is typically suppressed by glucose in the normal person. The failure to suppress growth hormone is a common diagnostic of acromegaly. To test this, the patient's GH blood level is measured both before and after they drink a glass of glucose solution. If they do not have acromegaly, the glucose drink typically will cause the GH level to fall. But if they have acromegaly, the GH level will tend to stay high. If the diagnosis is successful, patients are typically subjected to a pituitary MRI to ascertain the size of the tumor and whether or not the tumor is infringing on any of the critical body parts, such as the eyes, so they can perform surgery. As surgery itself, innovations have allowed for most pituitary tumors to be removed by transsphenoidal surgery. This means the surgeon goes through the nose to get to the tumor. The back of the nose points to the sphenoid sinus and an air passage in the nasal cavity. By making a small hole in the bone, here the surgeon can see the bottom of the pituitary gland and the tumor. The surgery is largely successful, especially if diagnosed early and found at a microadenoma state. This is why awareness is so important to provide early diagnosis. If you feel like you might have the symptoms of acromegaly, request the IGF-1 and oral glucose tolerance test for growth hormone. Treatment typically leads to patients' lives being improved or even saved. The following are photos taken of patients when diagnosed and then recent photos that show successful treatment. We call these our faces of hope. A special thank you to Anish Lakala with Ignite for helping us with this awareness video. Working together, it can help improve the future for patients. Thank you.
Thank you again for joining us, and go out and live your best life. You're in control. So I wish you a happy day. Bye-bye.
Thank you, Jill. Fantastic video. Really, really well done. And I'm sure it's going to add to the awareness out there in the community. Thank you very much for sharing that. Our next speaker is Catherine Jonas. She's a licensed marriage and family psychotherapist and board certified expert in trauma stress. She specializes in working with patients and their families to help them cope with pituitary conditions in particular. She speaks extensively on pituitary-related illnesses such as acromegaly and Cushing's, helping both the patient and their support system. In addition, she's also a certified geriatric care manager, and she runs her own geriatric care management and counseling firm in LA called CJ and Associates Care Consulting. This is the second time we are inviting Dr. Jonas here, so thank you so much for being here, and sorry about the delay.
to unmute. Can you hear me now? All right. Good morning, everybody. As I was just introduced, and thank you very much for having me back this year. I was very excited about presenting today and seeing everybody and seeing familiar faces from last year. So I was asked to return and to touch upon issues around mental health and acromegaly, because not just with all the dynamic information that we've learned so far this morning about the physiological and the physical needs of this illness, it's really important to talk about the emotional and psychosocial stressors. And so as a psychotherapist, that's really my focus. And so that's what this presentation will be about. When I see clients in my practice who are dealing with pituitary disorders, especially acromegaly, you'll learn about what we focus on in session and how we can kind of move through this. And just to kind of tag along with what Jill just said, is just really working together and staying present in the moment. So I'm going to move through these slides a little bit, and we're going to talk about why this topic is important. When I started presenting about acromegaly years ago, no one had ever been talking about the emotional and psychological issues. So we're going to really, focus on this. So first of all, when a patient comes to see me, they're quite distressed about the diagnosis. And so a lot of our work is just remembering that this is a diagnosis. This is part of you. It is not all of you, even though it feels like that, especially upon early diagnosis. So we're going to look at the physiological and the psychosocial aspects of this in the fact that your life is connected, and both of those are very connected. My focus with my patients is always on how well we cope with what we're facing in our life, any kind of stressor, not just a pituitary disorder. And then really how to learn more about how you want to live your life and integrate all of these aspects. So as far as the goals of this presentation, we really want to look at what your psychosocial stressors are. These are going to be different for everybody. So not everyone may have a partner, not everyone may have a child, not everyone may have work or occupational stressors. So we really want to identify that. So for those that are watching today, think about some of these as we move through these slides. We want to identify social changes. And as we know with acromegaly, there's a lot of aspects of this disease where if we're not feeling good about ourselves, about our body, we may not engage in social activities. We may not want to go to that family reunion or wedding because it's been many years and people may see us differently. So there's a lot of issues around that. We're going to talk about goals of coping. And we're also going to do some work around some cognitive behavioral aspects to how we see about how our thoughts are connected to our emotions and our behaviors. So if we look at the psychological challenges, first, we're going to be dealing with confronting our diagnosis. This is usually the first thing that happens, of course. And some of the issues that are addressed with my patients are my personal security. You go along life and all of a sudden, you may have had symptoms along the way that no one seems to be diagnosing. Nobody seems to be coming up with any kind of treatment or care plan. But finally, through the testing and through imaging, you're faced with this issue. So how do I incorporate this new information into my life? How is this maybe going to affect me in my relationships with others, whether it's work or family, and how will this change affect how I see my life moving forward? So again, this is all about the psychological, mental health issues with dealing with a pituitary disorder, especially acromegaly. And so what we want to do is just keep moving. Let me just focus on psychological challenges. So when we're dealing with like post-surgery maintenance, it's really important, as most of you know, how we deal with daily maintenance compliance. Are we having to deal with side effects of medications, persistence of symptoms after procedures after medications, breakthrough symptoms. How do we balance all these treatments? And maybe how do we balance healthcare professionals if we're dealing with, a neurologist or endocrinologist or primary care or all of these different, treatment modalities so that we can stay on top of our own care. And then what's your view towards maintaining all of this? So when we look at social and occupational challenges, this is really important for a lot of my clients. I want you to look at yourselves, like, since my diagnosis, have I changed in my relationships with others? Am I withdrawing? Have I chosen not to tell people what I'm dealing with in my life? Am I isolating? Am I turning down social activities? Dealing with, work commitments and not taking on things that I should be. I want to talk a little bit about coping. So coping and how we deal with coping, these strategies, we really want to look at how we kind of see the stressors in front of us and how we kind of use both behavioral and psychological aspects to tolerate or minimize stress. So these are all aspects of how we can cope with what's in front of us. So there are 5 main types of coping mechanisms, which I've developed. One can use each of these mechanisms within a given situation. And your goal is to really look at how you cope with things, how you cope with an initial stressor. So we're going to look at types of coping mechanisms. So first of all, this is my favorite one, and this is something that all of us as human beings are just instinctually, we have this fighting spirit. It's usually when we're feeling self-confident, when we feel like, I got this, I'm advocating for myself, I know what questions to ask the physician, this is a challenge, I have a positive, rational attitude. I really see the patient, when we're in the fighting spirit, the patient really takes an active role in their recovery. They're working along collaboratively with their treatment team. They're an active player with their treatment team. And there is an aspect of having some control over the stressor. So I may have acromegaly, it doesn't have me. Believe it or not, a coping mechanism that we also all kind of struggle with at times is avoidance and denial. So this is where somebody may deny the impact of the disease, they may minimize it, they may not focus on it and distract into unhealthy behaviors. And this is also where mood disorders come in. So when we talk about mental health, we often see patients move into depression or anxiety, like a generalized anxiety disorder with a lot of this. And so we want to be aware of not minimizing or denying our diseases. Oftentimes, patients will go into a coping mechanism of fatalism. So this is where the diagnosis represents a relative minor threat. I don't feel like I have any control. You're very passive. Any active strategies, are not present. You're just kind of turn it over like it's just in the hand of fate. I don't need to do anything about my condition. This is a very common coping mechanism that we all as human beings turn to at times. So believe it or not, sometimes when the body physically and psychologically just feels shut down. So these are feelings where we're completely overwhelmed and engulfed. Focus maybe on loss of life and impact and change of lifestyle. There's no control over anything that you can do. So this is a place where we don't want to spend a lot of our time in this coping mechanism, because this is where we can really lead us into some, dark thoughts and not wanting sometimes to live anymore. And this is definitely where you want to reach out to your support systems, maybe a private therapist, support groups to get back into a more positive view of things. Anxious preoccupation is very common for most of us. This is where we're compulsively searching for reinsurance. We may be spending tons of time on the internet. We're just not sure about what the world's going to look like. I can't cope with not knowing. And so that's something that we want to be aware of too. We always want to look at what we can control versus what we can't control. So controllable stressors are, who's our healthcare professionals? Who do we have in the cities that we live in? And is there a good healthcare team that we can work with? And then what are the procedures that I need in my life to correct this? If I do have a tumor, do I need to have this debulked? Do I need to look at what medications I can change? What different types of medications, injectables versus orals, and those different treatment modalities. And then, the fact is that I have this, the fact that I may not be able to control all aspects of this, but I can be an active player in some of the things that I can choose. So, how do we cope with controllable stressors? We want to utilize strategies such as problem solving, decision making, where I can feel in control of the decisions and I'm that active player in my recovery. As far as the uncontrollable stressors, so we want to become aware of the emotional response we have to acromegaly, and we want to be mindful of how our thoughts and our emotions and behaviors, which mean actions, all work together. Okay, so when we deal with the uncontrollable stressors, looking at, are there pleasant activities that I can engage in? What are some of the things that will make me feel better mentally? Those are going to be different from everybody. Relaxation exercises, deep breathing, mindfulness exercises. And then how do we want to kind of deal with managing symptoms? So, for example, when dealing with breakthrough symptoms, we want to really look at what treatment is and, looking at the different levels. How do we manage this? How do we reach out to our treatment team to get support around these? How do we deal with fatigue, body aches, joint problems, sweating, headaches? So it's the managing the symptoms that are very important to have a voice around, to speak up to your treatment team to manage these. It's really important to know that acro rage, acro fog, these are symptoms that are really important to speak with your healthcare providers about. They are real. And I know that a lot of patients that I have say that families think sometimes that they're used as an excuse or this isn't real, but there are biological changes in your body caused by the tumor medication. And so this is very common where we see a lot of mood swings. There's also some cognitive, we see kind of fogginess, forgetfulness, short-term memory, lapses that we see sometimes that's commonly called as acro fog. So be mindful of these symptoms that are, maybe happening. So the type of work that I focus on with my patients with pituitary disorders is looking at some cognitive behavioral theory. And what that means is there's a relationship between how we think about something and how we feel about something, and then how that shows up in a behavior. Behavior also, I'm referring to the word as like an action step. So if I think a certain way, about a situation, it's going to affect my behaviors and my emotions, and they're all connected. So let's use an example. Situation is the diagnosis of an illness. The thought that, let's say, comes in right away is, I'll never be the same. And the emotion that's connected to that thought is typically fear, sadness, depression. If we think to ourselves, we'll never be the same, it's pretty uncommon that we're going to be in that fighting spirit. We may move into hopelessness or helplessness. We may go into denial. We may go into anxious preoccupation or fatalism. So notice this part of the presentation is notice the thought that you have. What are you thinking about things? And it doesn't actually just have to be about acromegaly. It can be any kind of stressor in your life. I want you to pay attention to what you're thinking, what your thoughts are. And then the last part is the behavior. If we think a certain way that's going to cause a negative emotion, most likely the follow-up behavior or action is not going to be in our best interest to feel good about ourselves. So we'll then follow up with withdrawing. So the theory is that a situation not need to change. So a situation can be fixed, like a diagnosis of acromegaly, or that I have this, or I've got to cope with this throughout my life and deal with medication, or, focusing on, finding the right physician. But the way you see it is going to determine how, or the way you cope with this is really going to be about what your thinking is going to be around that. So automatic thoughts, what are these? We all have these. This is a thought that's so well rehearsed, you're not even conscious of it, whatever that core belief is. It travels so quickly, it just happens. And that thought is immediately focused then or followed by usually a negative emotion. And a thought always precedes a behavior, and it always precedes a feeling. So, an example, doctor office calls, okay? We have an automatic thought that something's wrong. Why do we never think that, oh, well, something's good? But we don't really kind of go there. It's usually maybe something's wrong. So if you think something's wrong, what is your emotional reaction going to be immediately? Fear, worry, anxiety? Do we move into a depression and not want to get out of bed? Do we call in sick? Core beliefs. These are underlying assumptions that we have about ourselves and others. Usually these are learned early in childhood. They're unconscious, and they can impact about how we interact interpersonally in those important relationships. These are very commonly held or irrational core beliefs. We all struggle with these. I'm helpless, I'm weak, I'm inadequate, I'm unworthy, I'm unlovable, I'm different, I'm not okay. All those things that we struggle with in our minds at times. What we want to do as a solution is disrupt the thought. So just because we feel something is true, it doesn't mean that it's a fact. Okay. And so what I want everyone to focus on is rational versus irrational thinking. I tend to like the term rational thinking as opposed to positive thinking. A lot of my patients say, how can I think positive? It's not positive. There's nothing positive about this. So rational versus irrational feels a little bit more solid to me and kind of based in reality. So how do you tell the difference between what's rational and irrational? And so we're going to ask ourselves 3 questions. Are my thoughts based in fact? Okay, so the doctor office calls and we immediately think, uh-oh, why is the doctor calling? Something's wrong. Well, first of all, is that based in fact? No, we don't know why the doctor's calling or why the nurse practitioner is calling. Second question, does my thinking help me in how I'm feeling? So if I think this way, how am I feeling about it? Is it helping me at all? Most likely it's not. And then the last one is, does my thinking this way gonna help me get to my ultimate goals and make me maybe behave in a different way, meaning return the call to the doctors or show up at my kids' rehearsal that day, whatever that is. If you answer no to any of these questions, you may want to consider changing your thought. So the doctors called you into the office to update you on a prognosis. So your irrational thought is, I know it's bad news. Ask yourself the 3 questions. It's not based in thought. It's not helping at all as far as how you're feeling, and it's certainly not going to help your overall goals of getting through the doctor's appointment. So maybe changing it to a rational thought. I don't know what the news is, and you know what? I'm going to handle it. That is a more rational way of thinking. So how do we change thoughts, feelings, behaviors? Right? We realize the old way of thinking is irrational. It's not helping me meet my goals. Maybe to develop a new thought, maybe to think of a new thought as a mantra, like, I know I can get through this, or I can get through this today. How about just being in the day and being open to think differently? Because these thoughts are so ingrained in us, we don't even know the difference. Visualization is a tool that I often use. I think this is a really important tool. You don't need to hire a therapist to do this. There's wonderful apps today and tools around visualizing. This is often used by, famous actors and actresses, professional athletes do a lot of visualization to focus on what they need to achieve. Mindfulness is a very important, useful tool. I prefer it for me over meditation. I like being more actively involved in shutting my brain. And so this is a wonderful technique where you can challenge thoughts and feelings over time. And it puts you in this kind of temporary state of being focused on an action. For example, walking can be an amazing mindfulness exercise, where as you're walking, you're actually focused on feeling the ground underneath your feet, or peeling an orange. There's different mindfulness exercises that can be very helpful when you're feeling anxious or worried. Best way to practice these techniques of changing our thinking is, if you have fear of public speaking, try it anyway. If you have fear of looking into work or starting a relationship or asking somebody on a date, it's kind of just check in with your thinking, think of a rational way, and then move through with the action. How do we make new thoughts grow? We practice. A person can see there's advantages in reframing a thought and just being mindful and repeating it. Practice, practice, practice. Repetition is very important. Routines are very important in changing the way we think about a negative situation. And then these are also some common cognitive distortions that we all fall into: all or nothing thinking. If I can't do all the things I used to do, then life's not worth it. That's a very irrational thought, but it's something that we can really move into. So maybe I can't do all the things I used to do, and there are many things that I still can do now. Catastrophizing, this is where we make a mountain out of a molehill, and that's something to really focus on as far as reframing your thought about catastrophizing. It's very common with anxious preoccupation. Irrational should statements. I should have done this. I wish I had done that. I could have done this. Watch out for the shoulda, woulda, couldas in regards to choices you've made, or, dealing with physicians, as far as if you didn't feel like you chose the right one or a different treatment plan. Be mindful of this and know that in the moment you made the right decision at the time. Watch out for the if-onlys. We want to stay out of being a victim. We're not a victim. We want to be an active player. We want to try to stay in that fighting spirit. Coping mechanism is most. So stay out of if I had onlys. Keeping stress under control is really important. All change in life makes demands on our energy and coping. All adaptation causes stress. So there's positive stressors, more kind of negative stressors. So, choose, the activities and the people that you want to be around who are supportive to you, that don't add unnecessary stress. Exercise based on what doctor's orders, what your body can do, is really, really important. You need to get a lot of rest. You need to eat well, stay hydrated, take care of yourself, whatever that looks like. And don't forget to have some fun in there and some play, and carve that in a little bit. Support groups. I can't say enough about acromegaly community and other support groups. This is where there's a common denominator. Everybody shares your story to some extent. Professionals, medical professionals, psychotherapists, we're not in your shoes. We don't know what things feel like. You do. And so if you're in a support group, others can connect with what you're dealing with. And there's such power, I think, in support groups. So I really advocate that. And when I see patients, I always want them to be in a support group. So my favorite quote, I always end with this: watch your thoughts, they become your words. Watch your words, they become your actions. Watch your actions, these become our habits. These become our character, and we then pass this down into our legacy. So there's a lot of power in how you see things and how you think about things. And I'll finish with this last slide. Thank you very much, everybody.
Thank you, Dr. Jonas. I can tell you, I learn so much every time I hear your talk. Really, really wonderful and excellent tips and pointers and coping mechanisms there. Thank you again. So for our next speaker, Dr. Charles Kim. Dr. Kim is the Director of Clinical Operations, Spine Service, RUSP Rehab at the NYU Langone Orthopedic Center. He's involved in teaching, research, and clinical services, integrating multiple specialties, including physiatry, pain medicine, and medical acupuncture. He's on the faculty of NYU Grossman School of Medicine in both the Department of Rehab Medicine and Anesthesiology, and he's heavily involved in resident and fellow education as well. He is kind enough to again share his knowledge with us this year. We did invite him last year as well. We shared lots of patients with acromegaly who Dr. Kim has very kindly helped. So thank you so much, Dr. Kim, for being here.
Okay, can you hear me? Thank you, Dr. Agrawal.
Yes, yes.
Okay, so I'm really happy to be back this year. The time does fly. You have to excuse me. I just want to make sure. Are you able to see my presentation?
Not yet.
Not yet. Okay. Oh boy. How did we? Let me see here. I apologize beforehand. I think I might have had this issue last time, but I think we got through it. Okay.
I see it now.
Okay, perfect. Okay, so good morning, everyone. I guess I'm the last presenter of the day, so I'll try to keep it brief, and we'll get started. So yeah, so thank you once again. I'm here to talk about pain management in acromegaly, and as a pain management specialist, my focus involves pain across many different conditions, and acromegaly happens to be a condition that I've seen over the course of my career. Just to give a few disclosures, I have no financial interest in anything that's discussed in this talk. I do consult, do some paid consulting work for some regulatory agencies, the Department of Health in New York, as well as the Department of Education. Okay, so basically, the patients I've seen with acromegaly, due to the anatomical conditions that are part of this condition, I mostly see arthritic conditions. So patients with acromegaly often will come to me complaining more of things like joint pains or spinal pain, back pain, neck pain. And that's really why they're coming to see me. They're not seeing me because they have acromegaly. It just happens to be that they have acromegaly. And it seems that this is a condition that is more predisposed to these conditions of degenerative joint diseases. And I have a particular interest in the spine, and I work in the spine center, so I work along with a lot of the spine surgeons. We also have therapists, physical therapists, occupational therapists who are very specialized as well. So we work as a team to try to help people with their pain, but also their, most importantly, to get their quality of life back. Okay, so this is a picture of some examples of what I mean by joint pain, and the spine I include there as well. The spine is a much more complex structure than to be classified as just a joint, but it is prone to degenerative changes. So you can see that joints span basically the whole body. We have so many joints. Anywhere there's movement, whether it's your wiggling of your ear or whether it's the wiggle of your toes, there's a joint involved. Okay. As I mentioned with the spine, you can see on this next slide a normal spine on the left, and then an example of an arthritic spine on the right. So you see how all the parts are just basically wearing out. And in acromegaly folks, we see a faster degeneration just because of the nature of the disease. Okay. We also see sacroiliac arthritis. I've seen that a lot in patients with acromegaly, and this is an area that really doesn't affect too many of say, non-acromegaly patients, but in acromegaly patients, we seem to see a lot of that. And that's where the pelvis meets with the rest of the spine and sort of like the keystone of the arch of the pelvis. So this is actually quite common area that I see for back pain with acromegaly folks. All right, so as I mentioned, I'm a pain specialist. I'm actually mixed trained, meaning I've trained in multiple specialties. So I also am trained in acupuncture and integrate that into my practice. So that allows me to sort of utilize more than one specialty or two specialties, but actually three, to try to find something that would help better, or a combination of treatments. So integrative medicine, you might have heard of it as a complementary and alternative medicine, and the terms are used interchangeably. You can consider acupuncture, yoga, tai chi, supplements like glucosamine to be considered under the umbrella of integrative medicine. I am also a physiatrist, also known as physical medicine and rehabilitation, and it's a smaller field, and this field is more of a conceptual field as opposed to a body part or a type of procedure. So, we focus on basically function. So we try to get people improved in their daily activities, things like spinal cord injury patients, strokes, and of course, chronic pain. So we utilize working with physical therapy, occupational therapy, speech therapists, it goes on and on. We also utilize modalities such as heat, electrical stimulation, things like that. And we can also prescribe and monitor assistive devices. So things like wheelchairs and also like orthotics, for instance, for like foot bracing or ankle bracing and spinal bracing, you name it, we can manage that. And then there's pain management. So pain management is a field that's, even though it's a subfield, it's quite broad as well. There's the interventional aspect where we use minimally invasive techniques to inject or to do minor procedures to help with pain relief. And then there's also the part of pain medications. And I throw surgery in here as well, because we work very closely with our surgical colleagues. And surgical management is also very, very key when it comes to pain management, because the hope is that if a person has, say, knee replacements or hip replacements, that their debilitating pain will be much more improved and they'll be able to enjoy their lives. Okay, so I mentioned acupuncture. So this is becoming a lot more common lately as more and more insurance providers have been continuing to cover for it. So basically, it's using very thin needles and we're placing it in certain points throughout the body. And the theory is that we're encouraging this flow of qi, which is a life energy force in Chinese medicine. And it's thought that when this qi is not flowing properly, disease and pain occur. So think of it as sort of like a traffic cop to try to move that energy along. Acupuncture is one of the ancient treatments for health, and it's been used for thousands of years. And the research has just been continuing to support it, and that is the main drive of insurance companies covering for more and more services. All right, so these are just some pictures of some typical acupuncture treatments. You can see how thin these needles are. These needles are barely thicker than a strand of hair, so it's not like a hypodermic needle where it's much thicker. You can probably place a couple of acupuncture needles through a traditional hypodermic needle. Okay, and throughout this talk, I'll present a few of the seminal or the very important studies that have helped put acupuncture more into the mainstream. This was published in Lancet in 2005. So this is one of the main studies that really put it on the map, acupuncture that is. And this study looked at acupuncture in osteoarthritis of the knee. It was a randomized trial. And basically, they found that after acupuncture, the pain and joint function were significantly improved. And they attributed that to acupuncture. Okay, and this is another very important study that came out around that time. So, this was the golden age of when acupuncture studies started to show up more in some of the major medical journals. You really wouldn't see studies like that because acupuncture was considered so alternative, but now we're seeing more of an integration. This was published in the Archives of Internal Medicine. And it is one of the largest studies to date, where if you look at the N is the number of subjects that they looked at, it was well over 1,000. And basically, it was a randomized, multi-center, blinded parallel group with 3 groups. So that's a very solidly designed study method. And they looked at patients with chronic low back pain using acupuncture and using verified and reliable measures, such as standard pain scales, and some studies have used functional scales as well. So what they found is that low back pain improved after acupuncture for at least 6 months. And the benefit of acupuncture, whether Virum or sham, Virum is true acupuncture, sham is considered fake acupuncture, was still almost twice that of conventional therapy. So this is kind of interesting because Virum, true acupuncture versus sham, I believe in this study, they stuck needles in points that weren't considered standard points, and they considered that fake acupuncture. They still had response to these treatments, and they were still better than conventional therapy. So, it's thought that, these exact points are not necessarily so fixed, but, just the impact of having thin needles placed in you can impart changes in your body and your chemistry, which studies have shown. Studies have shown that acupuncture can change or affect different activity in the brain. Acupuncture can also manipulate and increase certain neurochemicals. So it's really fascinating from more of a biological point of view to suggest how acupuncture works. And to this date, we don't know exactly how it works. And it is a very complex treatment. Okay. As I mentioned, acupuncture has been getting much more popular. In the midst of COVID, the CMS, the Centers for Medicare and Medicaid Services, in January 2020, announced for the first time that they were going to start covering for acupuncture. So this was probably the pinnacle of acupuncture in this country. It's very interesting due to the brevity of this talk. I can't go into the history of acupuncture, but it's fascinating how acupuncture had started in China and spread throughout the rest of the world. But their reasoning was that the drive that is to have this covered by CMS and Medicare was that they were looking for increasing access to alternatives to prescription opioids. So this is in response to this ongoing opioid epidemic that they were trying to address. And, they felt that this was a great time to bring acupuncture into more mainstream. Interestingly, they only approve it for chronic low back pain. So I have patients on Medicare coming to see me. They say they have neck pain or they have shoulder pain, and it's unfortunate that we can't work on those areas, but we're only allowed to focus on the back pain, on the lower back. And the Medicare, and just to clarify, Medicare will cover, but Medicaid will not cover for acupuncture. So Medicare coverage is 12 sessions within a 90-day period, and then they will approve an additional 8 sessions for those who have demonstrated improvements and response to the treatments. And they'll cover for a total of 20 sessions per year. So I'm hoping that a lot of these regulations and the breadth of different conditions may very well evolve and change as CMS starts to gather more data about the effects of acupuncture on our Medicare recipients. Okay, so going along the lines of integrative, Tai Chi is also a very good exercise. It is very easy to do. You might have seen these practitioners in parks very early in the morning, and it's basically just very slow rhythmic motions of the whole body. It is considered a martial arts. It's in fact very good hobby for those who have arthritic pains and pains in general, just to get the joints moving, also to improve just overall well-being. Okay, so this little study done in 2014 looked at Tai Chi for, once again, knee osteoarthritis. And basically, it was a review study looking at the other randomized controlled trial studies that were performed from 2000 to 2012. They looked at 6 randomized controlled trials, and they found that Tai Chi was effective. Okay, I often also would recommend aquatic therapy for a lot of my patients with arthritis. Aquatic therapy allows the buoyancy or the decrease of the effect of gravity on joints. So patients are much more comfortable when gravity is limited. Unfortunately, we can't do it on the moon. That would probably be better. Okay, yoga, also very good for patients with arthritis. Yoga, this is an example of some poses. And this is a study that looked at yoga for, once again, knee osteoarthritis in older women. And this was published in BMC, Complementary Alternative Medicine Journal. And they basically randomized a group to an 8-week program versus a control. And they found that yoga in combination with home practice was feasible, acceptable, and safe, and showed therapeutic benefits. Okay. As I mentioned, as a pain provider, I also provide injections, and perhaps many of you have had these. Basically, we're injecting medications, local anesthetics, certain substances, basically throughout the whole musculoskeletal system. Okay, and they can, as I said, include steroids, local anesthetic, and I also do something called synthetic viscosupplementation, which is basically it's a mimicking of the substance that our healthy joints produce. It's a lubricant, and I threw up just a wide range of different trade names. Okay, this is an example of this gel injecting into the knee. Okay, and basically, as I said, they mimic this substance called hyaluronate, and it acts like an oiling cushion to lubricate the joints. And for the knee, for instance, typically is 3 injections weekly, and on average, they tend to last about 6 months, and then we just repeat them. Okay, this is a study that looked at the viscosupplementation, published in the Cochrane database. They looked at 26 randomized controlled trials, and they found that there was significant beneficial effects. So basically, the insurance companies are pretty good with these injections and approve them quite consistently. Okay, there's also interventional procedures where you can see here. This is a fluoro suite where we use a special type of X-ray, which is a limited amount of radiation, so not as much radiation as a traditional X-ray, and it allows us to visualize structures in the spine and deliver medications and procedures very, very specifically. This is an example of an MRI which shows spinal stenosis due to arthritis, due to wear and tear of the disc. Sometimes they can start to pinch or reduce the size of the spinal canal, causing nerve pain and sciatica. And I'm sure some of you have this or know people who have this, and it can be quite debilitating. Okay, so this is a type of the pinching. You can see in the schematic a disc popping out, pushing on that red part and pushing out on the nerve right behind it, and that can cause that sciatica pain. Okay, so what we can do is use this guided fluoroscopy to bring a needle to these pinched areas and just inject cortisone around these inflamed and painful nerves, and that can often keep down the pain. It's not going to fix the problem, but it can certainly decrease it enough so that patients can go and benefit better from physical therapy, exercise, and et cetera. And as I mentioned, surgery is also very important in this, because not all cases are amenable or respond to this. And certainly there are cases where the anatomy is so severe that surgery is really the best option. Okay, these are just some fluoroscopic images of the typical epidural that allows us to very safely and precisely inject these medications. Okay, facet joints. In the spine, we have little joints called facet joints, and just like your hips, knees, or other parts, they also can be subject to arthritis, and quite often see these in my patients with acromegaly. So we can inject these as well with cortisone. This is a sacroiliac joint injection. You see how the contrast is visualized throughout the length of the joint. Okay, and then there's also radiofrequency ablation, which I specialize in. It's a modality. You can think of it as sort of like microwave, and it concentrates a heating energy to basically burn and destroy the nerve. Okay, and I do that in the spine predominantly, and it can help with a lot of the arthritis pain. So you're basically knocking out a nerve that you don't need to move or to feel. It just communicates the pain signals from the spine. And when you burn that, often patients will have on average 6 months to 2 years of pain relief. Okay, these are just some more schematics of, you see on the right, that small little branch of the nerve, where you see that little, I guess, burning caricature. And basically you're cutting the nerve grows back, and that's why it takes about 6 months to 2 years for it to grow back. And that's the duration where pain relief is hoped for. And often if the pain starts to come back, we just repeat it again. And as I say, I become their barber, so to speak, a barber of nerves, that is. All right, so this is a pain physician study in 2007 journal, and it basically reviewed facet joint types of procedures on spinal pains, and basically across the board, it was a moderate amount of evidence that it helps. So once again, because of this amount of research backup, virtually all insurances are pretty good with proving these with the right candidates. Okay, and this is a type of procedure for the sacroiliac joint called a simplicity probe. So it's a long probe that we can just basically do a strip burning of all the nerves across the sacroiliac joint, as I mentioned before. That could be helpful. Okay, and now we're seeing more direction towards peripheral joints, and this is the tough part because we need more research on these, but most insurances still consider these experimental, but we're basically burning specific branches of major joints like the obturator nerve in the hip, for instance, for hip arthritis, genicular nerves in the knee, and then shoulder as well. So those are also on the horizon to be more utilized once the research catches up. And then, of course, I can't forget to mention pain medications. If used appropriately and monitored appropriately, they can really help people as well. So, we can't practice pain management without pain medicine. And often when people hear I'm a pain specialist, they think all I do is prescribe pain meds. But as you can see from my talk, that is not the case. All right, so I think that's the last slide. And
thank you, Dr. Kim. Thank you so much, as always, for a great talk.
Welcome. Thank you.
Thank you. So we have a few questions on the chat. We are going to do a quick panel discussion, but we're going to skip the break in the interest of time. So I'm going to read out the questions first, and then we're going to try and answer them. Dr. Yuen, are you still on?
Yes, I am.
Okay, thank you. Thank you. Great. All right, so the first question I have is, what type of outreach is being done to endocrinologists who mainly treat diabetes and thyroid conditions, but may not be as knowledgeable about the differential diagnosis for acromegaly tumors from other pituitary pathology? So yeah, thank you so much for this question. And it's absolutely a vital point. We do want to educate not just endocrinologists, but all community physicians out there, including primary care physicians, neurologists, dentists, psychiatrists. Everyone should really be aware of the different signs and symptoms of acromegaly. But you raise a very good point. Not all endocrinologists specialize, so to speak, in pituitary tumors, but I will say that their general training does include pituitary diseases. I think larger centers are now moving towards a concept called a pituitary center. So basically they have a dedicated pituitary endocrinologist. They have someone who takes care of their surgeries. They have a neuropathologist who specifically looks at pituitary tumors. They have a neuroradiologist as well. So I think one of the ways that this could be avoided would be to go to a particular pituitary center. Dr. Yuen, would you like to add to that?
No, I think that's absolutely right. I think the outreach and the increase in awareness also requires help, I guess, from other folks as well. And Jill Cisco mentioned a great point today. I mean, her organization is doing a great job in educating not only providers but also the general public as well. And also, I think societies like the Endocrine Society and the ACE, they all would also do a good job in, or would could do a job in improving the awareness by having, these meetings, patient-centered meetings, and also perhaps also going out to the community to inform patients and providers that the condition is out there and it shouldn't be missed. So I think it requires a whole host of different folks from different walks of life to achieve this goal. And Nidhi, you mentioned the pituitary centers of excellence. Yeah, they are only found in certain parts of the country, but again, that's also helpful to locate them as well, especially for patients who are, when they are found to have the condition and they're not knowing where to go and who to talk to as well.
Right. Thank you. Yes, please go ahead. Yes.
A lot of the meetings that I attend are CME based in order to try to lure physicians. It's hard whenever you're dealing with a lot of physicians who 90%, 99% of their practice is focused on diabetes or thyroid issues. The key is trying to get them in. And typically, if there are CME credits involved, there's a higher chance of luring, physicians in. And in 2019, we actually combined with the Pituitary Society for part of our meeting. And I'll never forget, Dr. Melmed asked for patients to stand up that were in that meeting. There were about 500 endocrinologists in that meeting, but then we had over 200 patients at that meeting, and I heard a gasp. But in my opinion, one of the reasons why these meetings are so successful is because patients want to be heard. And they want this condition to be better understood. And, literally, we've got to continue to strive to reach physicians. The key to diagnosis is knowledge. Doctors can't diagnose what they don't know.
And I think medical schools too are important. They should play an important role in educating our next generation.
Correct.
Because they are the next generation and they are physicians. They're going out there, a variety of different specialties. So I think we need to do a better job in educating our next generation. Yeah.
Absolutely. I have another question, Dr. Dassi, Dr. Ewan, and everyone else, if you wanted to chime in as well. So this is a patient-related question. She says, I was diagnosed in 2008, and the tumor was surgically removed. Still, my growth hormone and IGF-1 levels are elevated. And since 2008, I've had Sandostatin LAR and now my CAPSA. She says, no tumor is showing on the MRIs. Do I have to be on the medication forever?
There are some studies that demonstrate that after a long term somatostatin analog treatment, there is the possibility to stop the medication after a long period of treatment. The fact that he or she had no adenoma on MRI is a positive sign to this. But I think that it will take a long time to stop the medication. And after a long time, you can try enlarge the period of medication, and after that, stop it. Yeah.
Also, the possibility if they have had radiation previously, there's also a higher chance that you might end up, hopefully in the future, to come off some medications.
Absolutely. And I would just add, if it's just medications, then it's unlikely to be stopped completely if the patient has not had radiation. So she's probably talking about being on the medication for the rest of her life.
Yeah.
I have another question here. I was diagnosed early in Jan this year in Canada, and I'm awaiting surgery. It was mentioned that the lower spine pain around the pelvis is not uncommon for acromegaly patients, which I do experience. Are there specific pain management strategies that are more strongly recommended than others for this unique condition? So Dr. Kim, this is for you.
Oh, sure. Yeah, so I'm glad that was touched upon, and I appreciate the question. As I mentioned, sacroiliac joint pain is quite consistent. I see that quite more often in the acromegaly population versus the non, and that's really it's a major weight-bearing joint that takes the brunt of the spine. So in terms of treatments, we first start with things like physical therapy, doing the right types of exercises, focusing on pelvic stabilization. Exercises can often help support that joint better. And I showed some images where we can inject some cortisone. And then there's also the radio frequency where we can burn the nerves across that. And basically that can help as well. And these are all non-surgical. A surgical procedure is called a sacroiliac fusion, which is done very, very rarely. And we would use this in cases where there's been pretty significant separation of the joint. And we usually see that in high velocity types of injuries. So for the most part, if you do have sacroiliac joint pain, and this can often be detected by certain physical exam maneuvers and typical patterns that SI joint pain displays, there are ways that we can approach it.
Thank you, Dr. Kim.
Oh, and I'm sorry, I forgot to add, also acupuncture can be helpful.
Thank you, Dr. Kim. There's one last question that we'll take. I have been diagnosed with a 2mm pituitary tumor and possibly a second of the same size. I am having significant growth changes throughout my skull, especially my ears and my nose. My IGF-1 continues to be low, 63, 74, 109, so there is no plan. I just learned that fibromyalgia lowers your IGF-1 level. And she has fibromyalgia, it sounds like. So would this be a factor in keeping my IGF-1 low upon testing? So it's someone where I think there's a suspicion. She sounds like she has some symptoms of acromegaly, but the IGF-1 continues to be low, and she also has fibromyalgia. Dr. Yuen, would you like to answer that question?
Yeah, I'm aware there's some literature suggesting fibromyalgia can lower the IGF-1 because of the changes in the pain sensation and also the pain appreciation. But I think if your disease, especially acromegaly, if it's severe, and most acromegaly patients have some degree of pain as well, I don't think the pain itself from fibromyalgia contributes substantially in lowering the IGF-1. I mean, I guess if you wanted to be absolutely sure, one can consider doing the OGTT to confirm that. But given that, and also maybe also changing the assay and going to, because sometimes assays can be variable from depending on where you have had that measured. So I think those are the things to look into if you're wanting to pursue the possibility of acromegaly. But certainly you really need a biochemical diagnosis before one can proceed to consider further treatment. In this case, surgery often is the first line of treatment if the diagnosis is confirmed.
Thank you again, Dr. Yuen, and thank you so much to all our panelists for sharing your time this morning. Thank you to all the speakers. Thank you to the panelists. Thank you to our wonderful attendees. And of course, thank you to the sponsors. I do want to quickly share my screen. And that, again, these are our sponsors. And a huge thank you to Cecilia, who is our department administrator. She's really the backbone of our entire department, honestly. And this is the quote that she goes by: keep calm, carry on. Nothing, absolutely nothing phases her. And I've never seen Cecilia be stressed. So thank you so much, Cecilia. And Acromegaly Awareness Day is November 1st. So this event really could not be more timely. Please absolutely log on. I know Acromegaly community, the website has a very nice following on this as well.